Good morning. How's everyone this morning? I'm Ann Garce-Taylor with AIM at Melanoma. And I'm going to start I'm going to wait about 30 seconds. I don't know if you're aware, you might have noticed the camera behind us. We are live streaming this event today, and we have people from all across the United States who are joining us. And so we want to give them a minute to load in, and then we will start the symposium. Give me about 30 seconds and we'll get started. Okay, we'll go ahead and get started. Once again, for the benefit of those folks who are joining us from all across the United States on Facebook and YouTube and Zoom, welcome to the UW Carbone Cancer Symposium. We are just so delighted to be co-hosting this event. I want to start my remarks this morning by thanking Dr. Albertini and all of our panelists today for participating in this symposium with us. I know that you are not here to see me, and I will be back later on to talk a little bit about our foundation. But my role here this morning is to explain how you are going to get your questions answered. I know you'll have lots of questions for our panelists today. If you are here with us in person, it is so delightful to have so many people in this room. It's just fantastic to see so many people. What we're going to do is have 2 live question and answer periods. What you will do is we'll have Allison and I will be standing on opposite sides of the room. You can simply raise your hand. We'll bring a microphone over to you, and then Dr. Albertini will take your questions. If you are joining us virtually this morning, then what we will need you to do, if you're joining us through Zoom, you will need to write your questions into the Q&A tab. You're welcome to put any comments that you'd like to in the comments tab. Tell us where you're joining us from. We like to know where everyone's coming from. Similarly, if you are joining from YouTube or from Facebook, please put your questions into the comment section. We'll get those written down and we'll get those to Dr. Albertini. And without further ado, I am going to turn the baton over to Dr. Albertini, and we will start this morning's symposium.
Thank you, and welcome, everyone. A very genuine and warm welcome. This is an important day, and what a beautiful day outside for this occasion. Maybe before I start my welcome, maybe just even take a minute and look around. We're really all in this together. And I think we're really with many backgrounds, with many stories, with many hopes, wishes, trials, tribulations. But we're here really with one purpose today, and that's really trying to learn more about melanoma and try to come up with some answers for this disease. So welcome both those of you in person and those of you with us virtually. Hopefully today will be informative and a chance to answer some questions and hopefully leave all of us with a improved idea of how we can all make headway against this disease. So the title is, for our morning session, What's New in Melanoma Care, from Safety in the Sun to New Research Approaches. So melanoma, as we all know, remains a common cancer. Estimates from the American Cancer Society for the current year, 2023, are for 97,610 cases, more men than women, and 7,990 deaths. Again, this remains a common cancer, a common problem. Our schedule this morning to try to help address this problem is shown here. Dr. Xu, professor in the Department of Dermatology, will start with a talk entitled Safety in the Sun. Dr. Heather Neuman will then speak about melanoma surgical management in 2023. I will then talk about what I see as a roadmap for continued progress in the melanoma clinic. And we'll then have a Q&A for really all of the faculty panelists. There's 4 of us, one whom I'll mention in a minute, but 4 of us will be sitting up there and taking questions. One request, the questions from the audience here will be live. Please, no personal questions, but try to make them more general for other individuals. Any of us are happy to take the personal questions separately, but I think it's important to make this so to protect your privacy, questions that'll be more for the general audience. And then we'll have a break. Dr. Ma will then speak about clinical studies at UW Carbone Cancer Center to improve outcomes for advanced melanoma patients. And then we're going to have what I really see as a highlight of this morning's session. 4 remarkable individuals, different backgrounds, different stories, different trials, different tribulations, like many other people in this audience, and they'll share their perspectives in terms of their melanoma experience, and they'll also be available to answer your questions as well. Kirsty Blattner, Ronald Parker, Kathy Stokowiak, and Stephen Carpenter. And we'll then come back and speak about AIM at melanoma patient resources. And we'll conclude with the 4 of us in terms of the 4 faculty, again, coming up and answering those questions that weren't able to be addressed in the first part of the session, and any other burning questions or questions that have arisen after them. So our first presenter is going to be Dr. Gloria Xu from the UW Department of Dermatology. And Dr. Xu will speak about safety in the sun. Welcome, Gloria.
Thank you. I need to be a little lower. It's like when I work on patients, I always have to adjust my table much shorter than most of my nurses. So what a gorgeous day outside. We're enjoying the best part of a best season in Wisconsin right now. So my topic, safety in the sun, seems very timely. I'm Gloria Xu, Mohs surgeon at UW. I'm very glad to be here to talk about association of sun rays, UV exposure, and the formation of skin cancer, and how to do some protection properly. I'm most grateful to see actually some of my patients walking over to me and say hello. It's a very special lecture. It's different than giving to my students and my colleagues. So thanks for being here. I don't have any conflict of interest. Objectives are very simple. I want to recognize melanoma burden and UV exposure as one of the main risk factors, and learn how to use sunscreen and other forms of sun protection in a proper way so that we can actually enjoy days like today, many, many days. As Dr. Albertini mentioned, American Cancer Society updates the annual incidence of melanoma. This year, their estimate is over 97,000 cases. And it's the 5th most common malignancy. So we have a lot to deal with. And later on, my excellent colleagues in medical oncology and surgical oncology will share with us how to manage advanced melanomas. But like anything in human disease, when you stay back and think in overall manner, what's really important, really do 2 things, right? How to diagnose melanoma early, because that matters, and how to prevent from happening. So early diagnosis really matters, because if you can see that the lines drops, this is a 5-year survival rate. So it drops as melanoma gets deeper and gets more advanced. So if we can diagnose them early in localized fashion, and then their 5-year survival would approaching to 99%. And then we don't really want to see patients like this. This is one of the patients I shared with Dr. Albertini years ago. When melanoma really kind of advanced and metastasized to the skin and any parts of your body, that's really late. So as a dermatologist and Mohs surgeon, I have to plug this in. I know most of you guys know how to evaluate your new mole or changing mole with ABCDE rules. I don't really want to spend most time on it, but just to say that this is something you can actually do self-check. And in this NCCN guideline, Dr. Albertini is a panel representing our cancer center. It stands for National Comprehensive Cancer Network. It updates all the cancer management guideline annually for all kinds of cancer. So it's a really authoritative consensus site. And clearly it tells us that tanning beds and sun exposure is one of the major environmental risk factors for melanoma. UV radiation is actually considered group 1 human carcinogen, kind of lumped together as cigarettes by WHO. So you might ask, what really happens to sun exposure and melanoma? Studies have shown that the majority of melanomas are caused by the sun. And if you have 5 or more sunburns in your lifetime, then it doubles your risk for melanoma. And then the early sunburn is, if you get sunburn as a child during your childhood, it is worse later on in life. So if you use sunscreen regularly, even just with the SPF 15 or higher, it cut down your melanoma risk by 50%, right? Think about how many things you can do to cut down a risk of skin cancer by 50%. That's sunscreen. So it's very important. And let's just dive a little bit deeper into what really UV does. And if you look at UV based on the wavelength, it divides into 3 different components. The UVC is very short. It never reaches Earth. It's just kind of reflected away in the ozone layer. And the middle part is UVB. That's the a small fraction of it kind of reaches to the Earth and then reaches to your skin. So if you look at that, the diagram here, the skin has epidermis, which is paper thin, and below that it's called dermis, and below dermis, that's subcutaneous fat. So UVB actually just barely touches epidermis and never reaches dermis. The majority that reaches Earth, about 90%, actually penetrates deeper. So the longer wavelength UVA goes all the way to your dermis. So if you look at all the studies, it shows actually UV as a photocarcinogen. The shorter one, UVB, it kind of causes burning, immediate burning and erythema or redness. It is shorter wavelength, so it's blocked by windows, and your car windows and your house windows, glass windows pretty easily. It does cause direct cellular DNA damage. So it's a more kind of immediate effect versus UVA that's longer and it causes delayed tanning. And it penetrates all the windows. So like people would say, well, I mean, if I drive in the car, should I still wear sunscreen? Yes, because the window doesn't block UVA, which actually causes more damage. It's low energy, but penetrates deeper and cause longer term cellular damage. So in summary, there are lots of studies already show that the UV rays will cause skin cancer, aging of the skin. You see more wrinkles and thinning of the skin, particularly on the face and around eyelids. And it causes immunosuppression and other damages. So I always want to put this fun part in, and I just kind of talk a little bit here, but I mean, I'm not going to do a quiz or anything. You don't have to be great at it, but if you want to shout out the answer, that's great. So like I said, over 90%, right? 90% of UV rays reach Earth, actually UVA. Only about 10% is the UVB, sorry. So false and truth. Some people say, I only need to wear sunscreen in the summertime. Is that true or not true? Yeah, correct. I mean, I think you guys already know. So people say, I do not need to wear sunscreen in cloudy days. Is that, my kids tell me that, so I had to educate them, yeah, so that's not true. So basically the answer is, even in cloudy days, and 90% of UV actually penetrates clouds. So, I mean, you don't feel it, but it still reaches your skin. And there is a refraction that actually amplifies UV exposure. The snow does the majority of it. Snow reflects 80% of it. So that's why when you go skiing, you definitely have to do some protection. Your eyes, your skin. The risk of indoor tanning, I'm not going to spend much of time on it, but this actually does a lot of damage to young women, particularly, and female population, because they like to get indoor tanning and get ready for vacation. So it has a mixture of different wavelength of UV rays. Majority is actually UVA, the deeper one, and up to 15% more UVA radiation than the outdoor sun rays, the natural sun rays. So it does a lot of damage. And then definitely studies already show there is a risk of melanoma formation in young female that does frequent indoor tanning. So how can we have fun in the sun? These are to my teenage sons. I have to plug that in because I always have to emphasize sun use, sunscreen use. My freshman year and sophomore year, both competitive tennis player playing for Middleton High School. They're doing sectionals next week, and then will be postseason individual state and team state next week. So we wish for that this year Middleton High will get title because they are very, very close. They seated #1 right now. Anyway, so how do you use sunscreen in a proper way? Our AAD website has very good information, but summarized in this slide. So we know that 1 in 5 Americans will actually eventually develop skin cancer. So it's very common. So sunscreen is one of the important tools. It's not the only tool you have in your toolbox, but it's definitely important. So when you use sunscreen, just a few important things, like you use SPF 30 or higher. You don't have to chase for crazy number like 180. So 30 is the cutoff number, because I'll explain later, because that actually blocked 96.7% of sun rays already. And you want to look for broad spectrum. Years ago, when I first started as a dermatologist, I have to tell patients to look for small prints on the bottle or tube, because it tells you what great ingredients will block UVA. But a few years back, FDA had a better regulation. As any sunscreen you purchase on the market, it's going to say broad spectrum. Or if there's no word, they cannot really do that word. That means that they don't block UVA. So you only need to look for a broad spectrum. And then there's no such thing as waterproof. It's only water resistant. And typically it tells you 40 minutes later, you have to reapply, or 80 minutes later, you have to reapply. Or if you sweat a lot, you have to reapply. And the common mistake is people don't use sunscreen enough. So 1 ounce is basically fill your shot glass of this amount will actually be sufficient to cover the exposed part of your body, like your face, neck, arms and hands, things like that. A lot of times if you use too stingily, like not thick enough, then you actually not use, for example, if you use SPF 30, you might actually only get benefit of SPF 15 or 10, right? Because you're using too thin. So those are common things to keep in mind. And then my patient asked me what kind of brand, and that doesn't really matter that much. It's really, you like to use it and you use it often, right? And you keep 30 or broad spectrum in mind. That's it. So in sunscreen, there are 2 different kinds, and the main category, one is called inorganic, and also called physical blockers, and the common names are titanium dioxide and then sunscreens that's chemical on the right side, it's a chemical absorber. So the difference is that the physical blockers, it just reflect the sun rays away. So never actually does anything to your skin. And then the absorbers, basically, they will do chemical reaction and then just make them into something that wouldn't do any harm to your body. So people actually have more allergic reaction to sunscreen with these chemicals instead of some blockers. Okay, so SPF, I know most of you guys already know, it stands for sun protection factor. It measures really how well a sunscreen product protects your skin from sunburn. So SPF 30, which means it actually allows about 1/30 of UV rays kind of reach your skin. So, it basically protect 29 out of 30s, right? So that's your math. So 50 will be allowing 1 out of 50 going to your skin. So, with that in mind, is that false or true? It's like if we say sunscreen SPF 30 is twice as good as SPF 15. Is that as simple as that, or it's not true? It's not true, correct. Very good. And then is there any sunscreen that could filter sun rays 100% if you use 100? That's not true either, right? Because basically that's your simple math. As I said, SPF 30, it just blocked 96.7%. That's how you do your math, because it allows 1 out of 30s, right? So SPF 15, that drops 93.3%. So if you have SPF 100, that basically block like 99%. So nothing is 100%. You still have to use your judgment. Again, our AED has really excellent information for public. And if you just go into the website of AED, American Academy of Dermatology, I have a lot of question and answers for sunscreen use. So I have to mention other means of sun protection. Obviously, sunscreen is not the only way. So you seek shade. You also wear really good UV protection clothing. Nowadays, like they're long sleeve, they're easy to breathe. They look colorful. You do wide brim hat, and then common thing people forget is your back of neck, your ears, right? So you have to cover that, and sunglasses for your eyes, because it's really hard to apply sunscreen around your eyelids. When you sweat, you just kind of, your eyes can really, you will become like watery, things like that. So you want to avoid the middle day, like a 10 a.m. to 2 p.m. Sun exposure as much as you can. And then for people like really work outside, I mean, you want to drink plenty of fluids, right? You get too hot and losing fluids. And I also want to just plug one slide in just to mention that there's common misunderstanding that, you know, people worried if I do sun protection, would I get vitamin D deficiency? Yes, I mean, the vitamin D deficiency, vitamin D, the skin is one of the big organs like in the vitamin D formation. However, sunscreen use wouldn't really result in vitamin D deficiency if you can just properly take that in your diet. So there are, you know, you can take from your diet or you can actually just do supplement. And there is a numbers you can follow, like for adults and for children, the international unit, how much you need to take. I'm doing good on time. All right. So I really want to thank my patients and my colleagues for all the support. And I want to thank Derm Foundation to support my career all these years. I got Derm Foundation career grant for one of my study, actually related to skin cancer, melanoma, and squamous cell carcinoma. Thank you. And here's my email. If you guys have questions like you can think of today, you know, think later, you know, more than welcome to just reach out to me. Thank you very much for your attention. And I want to introduce my wonderful colleague, Dr. Heather Neuman. You. Yeah, you get it. Yeah.
Just a minute to see if I can get this off. I don't,
That's right. Thank you.
but I don't know, let's see. I know, it's like the funny screen here,
Yeah.
though.
Oh, I see what you mean. I'm coming back.
Yeah,
I think you're maybe smarter than you guys.
well, it's somewhere on here, and I just can't figure out. Maybe it's here.
Can you do it?
No, because it's not here. You know what I mean?
Right.
Well, we don't have this, oh, here, maybe it's not, there's like a double screen that we don't have, is the problem.
Here we go. We have a AV person.
Yeah, do you know how to get that
Thank
part?
you.
Because I can see the Zoom, but it's not on this computer screen. It's up there. No, it's down there, you know, because it's still, it's just with the double screens, wherever.
There it is. You're on it.
Oh, yeah.
No.
No, Bill, that's saying leave, don't leave the webinar. Does the mouse go over there?
Yeah, can you take it in?
Oh, you did? Oh, there, okay.
There it is.
Do cancel first. And then you should be able to go up top and make it go away, right?
Yep, now we can. Should be able to.
No, that still did the leave webinar. So I think they'll have to do it on that screen just to.
Try moving it up on the screen. There you go. And then just Xing it out. Right there. That should do it. Yay.
Do you want that down below as
Yeah,
well?
and then
Okay.
just pull that.
Grab that. No,
No, you don't want to leave.
looking for.
Can you pull it to the bottom though? Just pull it
Yeah.
down to the bottom. All the modern. There we go.
Make y'all happy.
I'm gonna try and ruin it by like, I think. Is that, can I just X that? Is there an X there? No. Where's more? Is it this way? All right. Tell me where to go. Down? Yes. Now let's figure, okay, well, let's look, well, I need a screen here though. Hold on. Okay. That was very dramatic. I'm excited to follow Gloria. I have questions for her for our question session because my kids have the same sunscreen issues, so it'll be good. I'm today going to do sort of a big picture view around sort of what I think about surgery for melanoma and some of the changes that I think we're thinking about. So we'll talk a little bit about primary melanoma, local and transit disease, lymph node disease, and then metastatic disease. So I have a few case presentations buried throughout. So this is a 55-year-old woman who presents with a changing mole on her back, has a biopsy by dermatology that demonstrates melanoma intermediate thickness, so 2.0 millimeters, no ulceration, and she's referred to surgery. So I wanted to talk a little bit, talking about this question about how wide is wide. So the main treatment for melanoma is a wide local excision. I will say historically, we did 4-centimeter margins, which is really, really big. So thinking about 4 centimeters on each side, this would be the size of a popsicle stick, kind of as a diameter around in the back. And there were some clinical trials in the early 80s there were some done in the US. This is the intergroup study that I have up here, others done in Europe, that really asked the question, can you do 2 versus 4 centimeters? And is there a difference in local recurrence rate? So this trial, which randomized patients to one or the other, showed that the rates of local recurrence was really similar. It obviously makes a big, big difference in terms of the morbidity of what you have to take out. And this became the new standard. So our NCCN guidelines, which are the guidelines we follow for treatment, most of them now have either 1 centimeter for thinner melanomas, 1 to 2 kind of in the gray area, but 2 centimeters is kind of as big as it gets. That was a really big improvement over these really big, big holes that we would make. But it's still, it's still not great. So this is a simple kind of elliptical closure. Those scars under tension, they get wide. This is a more complicated advancement flap. This is better, I think, because it has less contour change, but it's still a big surgery. And then for some body places, you still end up having to have a skin graft, which if anyone's had a skin graft, it just takes a long time to heal. And that skin is never quite as robust as kind of your normal skin. And so one of the trials that should be opening up at UW within the next month is a study from SWOG, which is one of the big cooperative groups. It's called the MELMART study, and it's in Europe, Australia, and then in the US. And it's really asking the question, can we even go narrower? So it's looking at pretty broad inclusion criteria. So I would say most people who have a melanoma over 1 millimeter are eligible. And it's randomizing people to a 1 centimeter margin versus 2 centimeter. So this is going to be a really important question of, just like going from 4 centimeters to 2 centimeters is a big difference when it comes to your skin. The same thing is going to be true. And I think this study has the potential to be another practice change where all of these things in red are going to get potentially narrower in terms of the excisions, which I think is going to be a really important study. And I'm excited that we're going to be participating in it. So as a second case presentation, I wanted to talk a little bit about local recurrences. Our wide local excisions do a good job. I would say local recurrence rates are low, but they're not zero. And there's local recurrence comes in lots of different flavors. So this one has a really tiny single spot on the leg, but there's some that look like this that are obviously much more advanced. And then this one, which is even more subtle, where it's in the body of a skin graft and you can just barely see this little shadow. How we manage these are really different. So for something like this, a single little nodule, doing another surgery probably makes sense. For things like this, systemic therapy, so some of the things that Dr. Albertini and Dr. Ma will talk about, it's going to be the right answer. But then something like this, where it's just this little shadow, it makes sense to do surgery, but strangely enough, where this is on the front of a leg, that skin graft is already there, there's going to be some morbidity doing it. And so the question's always, are there other things that we can do? And so one of the other things that I think is pretty novel, it has a pretty narrow niche in terms of when we use it, is Imlygic, which is still the only oncolytic viral therapy that's approved in the US. And the idea behind this is a figure that even I can understand as a surgeon, but the idea is that we actually inject this virus, it's a modified herpes virus, into the melanoma. It infects the tumor cells and basically kills the cells, just like viruses do. It spills out all of these melanoma particles. It actually spills out more virus. All of that boosts the immune response to the area, stimulates immune response to then start killing the melanoma, almost like a vaccine. So it's sort of boosting its own immune system locally in that area. Eventually your body clears it, and so it's a repeated injection over time. And so, it's coming in every 2 weeks, and then every 3 weeks, and then every 2 weeks until it's gone or it stops responding. So we've used this, and again, we probably use it for fewer people than the company would like, and it's because around the same time that this was being developed, the really effective systemic therapies were also being approved. But for a patient like this, it kind of feels like overkill to give them sort of some heavy gun systemic therapy. So we used Imlygic, where we just injected that local area. And over the course of a month or two, it completely resolved. And we actually did a biopsy to prove that there was nothing left. And she went on to live the rest of her life. There's other more dramatic cases. So again, this is a picture I showed that had more advanced disease. Started with systemic therapy and it stopped working. And we treated with Imlygic, and you can see that the disease just sort of disappeared. We biopsied these pigmented, and it was actually just macrophages, which are immune cells that had pigment in them. There wasn't any viable melanoma anymore. So for some people, this treatment works really great. I put this up just as a cautionary tale that it's not perfect. I think it works for a small proportion of people, but for those patients it works for, it's a really great option that we have that we can fit in with our other treatments. So case presentation number one, again, this is that 55-year-old with the back melanoma, came to see me. And so I wanted to talk a little bit about what we do for lymph nodes. So on exam, her lymph nodes felt normal to me. And so what we do for people who have clinically negative lymph nodes are do a sentinel lymph node. So the idea is that you inject a radioactive tracer kind of around the place of the primary melanoma. We also inject a blue dye. Those get taken up into the lymphatics. They travel to the first lymph nodes that part of the body drains to. And if we're going to be worried about melanoma being somewhere, that's where it would be. And we actually take those out then and give them to the pathologist. Why do we do a sentinel node? It's really prognostic. So if you have something in the sentinel lymph node or not, it really defines how well you do. What that means is it opens the door for when we think about doing other imaging. So making sure that we don't see things other places in the body or some of the other drug treatments. And so at least the older data doesn't show that doing a sentinel lymph node biopsy makes you live longer. But I think it's really important information that we act on. When we find something in the lymph nodes, the question's then, is it enough to do the treatments that Dr. Ma and Dr. Albertini talk about, or do we have to think about doing more surgery? And historically, when I started in practice here in 2009, we did completion lymph node dissections. If you had a positive lymph node, we immediately took you to the OR and did a bigger lymph node surgery. And the upside of that is that you cleared out if there's, we don't have a way to find that second tier of lymph nodes. That radioactive tracer, that blue dye goes to the first tier. Those are the sentinel lymph nodes, but we don't have a way of knowing what else is there short of going in and doing that full lymph node surgery. There's obviously a lot of downside. So having to go back to the OR, obviously more pain, drainage tubes, some range of motion limitations, and then lymphedema is the main thing. And I just put this picture up. We don't see this very often now because we're so aggressive with working with our occupational therapists and lymphedema therapists, but there's a lot of reasons not to do a completion dissection if you don't have to. And so there's reasons behind, and the other thing we know is that when we do go back and do this bigger lymph node surgery, most people don't have additional disease. And it's because what we're finding in the sentinel lymph nodes is such low volume disease, and those lymph nodes are really selected to be the ones most at risk. So 80% of the time we would do this bigger surgery and not find anything. And the volume of disease was really low. So again, that sort of speaks to the fact that the sentinel lymph node removes the disease in a lot of patients. So the MSLT2 study, which now probably has been out for 5 or 6 years, was really asking this question. And it took people who had a positive sentinel lymph node and randomized them to have that completion lymph node dissection where we take out everything and get all the badness that comes with it, or just observation. And the observation is serial ultrasounds and physical exams over the course of 5 years. And this study showed no difference in survival, whether we do that lymph node surgery right away or not. With a caveat that there's some proportion of people who are going to have disease progress when we're watching them with ultrasounds, and they get that lymph node surgery at a delayed point. And so what that tells us is for those people who might have something else still there, there's not a difference whether we do that surgery right away for everybody or watch and only do that surgery for the people who really need it. So this is our current standard. So as long as people can come for ultrasounds and regular exams, which, I know I'm very pleasant, but I know no one wants to come see me that often, but it's every 4 months for the first 2 years, every 6 months out to year 5. And so this is what we do. And I tell people when we follow you, 25% of the time we'll find something that's going to require the bigger surgery, but 75% of the time you'll continue. And these numbers, I also will say these were pre-effective adjuvant therapy. So pre anything that Dr. Albertini and Dr. Ma will talk about. So these rates might even be lowered. So the last thing I'm going to talk about, and this has been an area that I think has also evolved. So before systemic therapy, surgeons just sort of were relied on to do a lot of stuff that we don't do now. And so this is another place, just like for local recurrence, metastatic disease comes in a lot of different flavors. This is not a patient where surgery is going to have an effective role. Maybe even not this one, but this one where there's just this one, and actually I don't think my pointer works up there. There's just an isolated lung lesion kind of up at the top, or even this patient where, I think I circled that one, has this is actually on the back, but so has a soft tissue mass on the back as the only spot of disease. So traditionally we thought about when you have metastatic disease, sometimes surgery makes sense if you can remove all the disease. So if you get people back to having no evidence of disease and you can do it without hurting them very much. That's for these two, that solitary lung lesion or that soft tissue mass on the back. Rarely you need it to get a diagnosis. I would say our radiologists are so great, they can get us a tissue diagnosis without surgery. Sometimes it's to address a current symptom. So if you have skin lesions, like metastatic skin lesions that are ulcerating and draining, sometimes doing surgery for that makes sense. And sometimes it's to prevent an impending problem. So this is a PET CT, that area kind of in the upper left-hand quarter is a small bowel lesion, which is going to cause an obstruction if we didn't remove it. So these are the reasons we used to think about doing surgery. Now that we have effective drugs, I still think these all make sense for some people, but there's a bunch of new ways that we would think about surgery. So sometimes we have patients who most of the disease is responding to immunotherapy, and you get a little clone that starts to grow. And this isn't totally data-driven because it's really hard to have a randomized trial to support this. But it makes sense that if you can go in and take out that clone that's starting to outgrow the immune system, maybe you can continue getting leverage out of the treatment. Sometimes it's that you've been on treatment for a while and you can remove the small amount of disease that's left and let people have a drug holiday. I think all of these are these new and evolving ways that we're thinking about it. And so I have one last example. This is a patient who presented, I'm going to try and get this up just because they're a little bit subtle on the scan, for goodness sakes. So he has about 3 spots down here and then has this one spot here. And this is someone who, because there were multiple spots that we could see on the PET CT, the idea that there was likely many more made it not someone who I was super enthusiastic about doing surgery for, because I didn't think we could get rid of all the disease. So we started immunotherapy. This is what happened after the first 6 months. And the only thing you can really see is that small lymph node is still there. Everything in the lower leg is completely gone. As we kept watching, though, that spot in the groin started getting bigger. And so this is a patient where that idea that there's a clone of disease that's sort of outgrowing things, it makes sense to go in and do surgery for that. And we did that for them, and they had a strong, long period where there wasn't actually any disease. So these are all changing areas, and I was trying to Google, like I like to have images to go with the end of the talk. And when you Google changing area, you actually get a changing area, which feels really good for this time of year and going into the summer. So I left it there. But all of these areas where we think about surgery are changing and evolving. And they're really changing and evolving because of the systemic therapies. I think surgery is always going to have a role for primary melanoma. I think some of the complicated stuff I do around closures, that may all go away if this Melmart study shows that narrow margins are okay. Local recurrences hopefully will go away. Metastatic disease will hopefully go away. And so I think it's just an evolving area where we keep watching. So thank you. Now I'm going to try really hard now that we like fix this to make sure that I can find Dr. Albertini. So I have the privilege of reintroducing Dr. Albertini. As you know, he is the mastermind behind this of everyone coming together. And so has also been really a driver of changing my clinical practice, making me think about how and why we do surgery. So
Thank you, Dr. Neuman, for that very kind introduction. And I'd like to say the title of my presentation, Roadmap for Continued Progress in the Melanoma Clinic. And while not officially covered in these slides, maybe I'll start with an aside. And actually one is continued outstanding colleagues, those of us multi-specially working together. And hopefully that one message from this morning, perhaps not officially written, but will be a takeaway in terms of the different talks. But really outstanding individuals, such as from dermatology, Dr. Xu, from surgery, Dr. Neuman, medical oncology, Dr. Ma, you hear about shortly. So again, not officially covered in these slides, but I do want to call that out in the very beginning, that I think one important thing are many of us really committed to the cause, working together in a collaborative fashion. This is my disclosure slide, and these are all support given to the UW for clinical trials. So again, I've got no conflicts related to this presentation. I'll begin by giving a few melanoma facts. The first, and really important to emphasize, that early melanoma is curable. Melanoma, when caught, detected, recognized, diagnosed early, and managed early, is curable in most individuals. So it's that important fact that if you identify something on yourself, on a friend, on a colleague, on a stranger, that person goes in, gets it taken care of early. Early melanoma is curable. It's important, despite all the great advances we'll talk about, remember that one very basic important fact. The second is that melanoma that spreads to distant sites, so-called distant metastatic disease, is serious and can result in death. We'll talk about many advances, but in spite of those advances, it's also important to remember that fact, that again, melanoma that spreads remains a serious problem. Importantly, new treatments, and we'll emphasize those today, give hope. And that's an important four-letter word, hope, and are improving outcome for many patients with metastatic melanoma. So my lecture outline is shown here. I'll begin in the dark ages. I'll transition to the age of enlightenment. And I'll conclude with my vision for a better tomorrow. So the dark ages, metaphorically speaking, for patients with melanoma is that time before 2011. We had painfully few effective treatments. Median age in the 50s, median survival 6 to 10 months, and 5-year survival rate less than 5%. This can be summarized in a brief sentence: metastatic melanoma is a bad disease. Our treatment options before 2011 included clinical trials, and in my opinion, really offered the best opportunity for patients. High-dose IL-2 or interleukin-2, a very intensive treatment given in the ICU setting for really a very small subset of patients. And even then, the chance of responding, meaning getting smaller, 16%, 1/6, and durable responses, 6%. We had chemotherapy that had various forms of ineffectiveness. I list one, but they were equally ineffective. That's what we had, clearly a dark ages. But during these dark ages, there was many important things happening. There was much research going on in the research laboratory that ultimately found its way into the clinic. So these laboratory insights, these basic studies that were then translated into people, really resulted and offered the opportunity for what I'm using here by analogy, the Age of Enlightenment. So I'll give a few examples. And one of these laboratory insights was that some melanoma cells contain targets for therapy. Again, what one needs to identify are certain aspects about the cancer that's distinct and separate from the normal cell. You want to find something, a target, something on the cancer cell that can basically call it out, can distinguish it, can identify it as being different, and that can give you an opportunity for a therapy. Importantly, it was identified that some of these targets control what makes the cell grow. They're involved in what's called cell signaling pathways. So if one could target those pathways, one in fact could interfere with the cell growing and kill those cancer cells. That was a huge discovery and resulted in the approval now of many so-called FDA-approved therapies for patients with advanced melanoma. Initially, these were given as single, what are called BRAF kinase inhibitors. The target that's been exploited to a beneficial perspective, the greatest is the so-called BRAF mutation, that being present in about half of patients with cutaneous metastatic melanoma. Many similar drugs were then developed, and it was then discovered that really these are best if given in a pair. So the currently approved pair, dabrafenib and trametinib, venurafenib and cobimetinib, and encorafenib and binimetinib, different pairs, BRAF kinase and MEK inhibitors, they basically go at targets in the cell that interfere with how the cell grows and can interfere with how the melanoma cell is growing. So that's on the positive side. That's great news. On the not as great news, the one obvious caveat is targeted therapies can only work if the melanoma cell has the target. As mentioned earlier, about half of the melanomas have the BRAF mutation. There's other targets, other therapies being developed, but again, still one prerequisite is that the cancer cell has the target for which this targeted therapy is identified. But even if the target's there, another overarching problem is that most melanomas develop BRAF inhibitor resistance. So again, these are important targeted therapies. They've helped many individuals, but the so-called median duration of working is about 12 to 14 months. They can work sometimes in days, sometimes in weeks, sometimes in months. Sometimes they don't work. The chance of working may be 70% or even better. But even when they work, and when they work dramatically, usually 10, 12, 14 months later, the cancer is growing again. So a huge item for further laboratory work is trying to identify mechanisms of resistance to these targeted therapies, and identifying new treatments to give in combination or subsequent to progression after BRAF inhibitor therapy. The second insight, and this one was huge, was that immune cells, our T cells, can recognize melanoma as foreign. Our T cells are those immune cells in our body that recognize foreignness from self. That's how we've really evolved as a species. We really have these T cells that can recognize infections and clear infections. Shown in this cartoon is the exquisite specificity of the T cell with its so-called receptor. Is that showing up there? Maybe not. But the T cell with its receptor recognizing a foreignness of peptide presented by the cancer cell or antigen presenting cell. They can second costimulatory signals. The important message is that we have in our bodies T cells that can recognize cancer as being foreign, as being non-self. This was a huge discovery. This discovery was way back in the dark ages. I remember these initial papers, these were back in the early 90s. So this was going on when clearly no treatments were working. But there was so much optimism, so much enthusiasm, because the immune system, when you think about it, is truly an ideal anti-melanoma weapon. There's a diverse attack. There's many types of immune cells we have, T cells I spoke about, NK cells, et cetera. And some of these have exquisite specificity in their targeting. They can see these minimal changes from self, and you can have these T cells then reacting against the cancer cell, the foreign cell. And immunity, if achieved, can last a lifetime after effective activation. This was clearly the promise of the effective immunotherapy. It raised the possibility of using the patient's own defense to fight against the cancer. The cancers are kind of smart. And we then basically, this was also going on in the dark ages, but we realized that we needed more strategies to get more melanoma reactive T cells. Part of it was a numbers game. As shown here, there were a few number of melanoma reactive T cells, huge number of T cells, and not enough to do the job. That was part of the problem. But the other problem, and even a bigger problem, was the presence of breaks. Our immune system has evolved where once the immune system is turned on, there's a natural defense mechanism that then turns it back off again. We're not always fighting the flu we had last year. We need to stay on our toes and basically fight the next infection that comes up. Similar to cancer, the T cell can initially be active, but then there's a break. There's a natural part of our body that then turns off that immune activation. It disables the T cells from being active. So the discovery, and this was huge, and this has revolutionized a care of the melanoma clinic. It is now translated to many other clinics as well, other cancer histologies, is that if you disable those breaks, if you leave these T cells turned on, then the T cells can really fight against the melanoma. And shown in this cartoon is what you can then see happen. You can see these T cells, breaks unleashed, being able to go and potently attack against the cancer. This is coined or termed immune checkpoint blockade. Again, this is really a revolutionary insight that happened again as the dark ages were starting to transition to the age of enlightenment. I'll give a few analogies to show how this is working. As many of you may recognize, this is a street in San Francisco. Pretend you're the car at the top of the hill, and the goal is to get right down the middle, past the stop sign, staying straight. These immune checkpoint blockade drugs take the brakes off. You point the car down straight, give it a push, and hopefully it gets right down past there. Cancer goes away. That's the goal. That's the strategy. That's the theory. Have any of you seen Lombard Street? That also exists. Take the car at the top of the hill, cut the brakes, give it a push, keep your fingers crossed. There can be cars parked on the side. There can be other items on the side. These are called immune-related side effects. What happens is the brakes are taken off all the T cells, both the ones you want to take the brakes off to get down straight, but also the ones that basically can result in side effects. And these side effects can be serious. These side effects can cause many so-called immune-related adverse events. These can be incredibly serious. It's important for the recognition: colitis, inflammation of the colon; hepatitis, inflammation of the liver; dermatitis, rash; hypophysitis, inflammation of the pituitary; thyroiditis, inflammation of the thyroid; adrenalitis, inflammation of the adrenal; pneumonitis, inflammation of the lung, and really many other itises, myocarditis, you name it. So again, many important and serious immune-related side effects can occur. It's really important for that recognition. But having said that, this is still a huge, huge breakthrough that has revolutionized our care. We've learned the importance of early recognition, early management, early detection. And what's also been discovered is that when you manage those, you can still have the good T cells that you want to have activated still do their job against the cancer. So right now, we have many FDA-approved immunotherapy drugs. IL-2 is still approved. It was approved for quite a while. We don't use it very much. Then we have the so-called immune checkpoint inhibitors. One's called anti-CTLA-4. At this point, it's a second-line treatment because we've developed better tools. We have the anti-PD-1 drugs, pembrolizumab and nivolumab. We've also learned that in the advanced metastatic setting, combinations are actually better. So nivolumab and ipilimumab, or nivolumab and relatlimab. They're better in terms of outcomes. They also have, as you might predict, more side effects as well. There's also a triplet, putting in a targeted therapy with the immunotherapy. That probably has got a pretty small niche where it works, and for many of us, it's still not entirely clear if that's better than giving the treatments in sequence. And then, as Dr. Neuman mentioned, TVEC for locally advanced disease. So I've been speaking about advanced disease that's distant metastatic, metastatic to distant sites. What's also been an important step forward is so-called adjuvant systemic therapies. So adjuvant means in support of the primary therapy. And the primary therapy in melanoma oftentimes is surgery. And we discovered that some of these treatments that have demonstrated effectiveness once the cancer spreads can also decrease the risk for recurrence. It's also increasingly recognized the importance of close and comprehensive collaborations between surgical oncology and medical oncology, and a newer approach, so-called neoadjuvant therapy. That's you give the systemic treatment first, then the surgery, then more adjuvant treatment. And actually, in some patients, that is a even better, further benefit than giving just the adjuvant therapy after surgery. And actually reported just earlier this year for the drug pembrolizumab, 3 cycles followed by surgery, followed by 15 cycles. So again, a full years of therapy is better than surgery followed by 18 cycles of pembrolizumab for patients with identified resectable disease. So again, this is a fast-moving field, an important one, but again, really gets at how I started my lecture with comments not initially planned, the critical nature, the essential nature of the close collaboration between the different specialists. So this slide was given to me by my actually friend and colleague, Dr. Michael Atkins, several years ago, and kind of summarizes treating melanoma, present and vision for the future. And this was in 2015, so these curves have changed a little bit, but still really makes the point that I'm trying to discuss here. What we had in the purple was what was in the past. We had chemotherapy and other types of ineffective treatment that essentially didn't do much for survival, very few long-term survivors. We then had the targeted therapies, the ones that I mentioned, and then improved outcomes, but fairly few long-term survivors. We then had the immune checkpoint blockade drugs, initially ipilimumab, and then nivolumab and pembrolizumab, then the combinations. And then actually with the combinations, we're seeing even 40 to 50% of patients with durable benefit. That's great, but you guys can do the math as well as I can. That's great for those patients. How about the 50 to 60% where it's not doing so? So I'd like to have the last part of my lecture be my vision for a better tomorrow and try to convince you that I really believe we have a roadmap for going forward. I will share a roadmap for a bike trip with several of my kids several years ago. We had a starting point and an end point and great companions for the trip. Our starting point are basically where we are now, with patients with a very serious cancer and need for better treatments. The roadmap there is shown in this picture. The roadmap in terms of the melanoma clinic is that really transformative insights in the lab will continue to guide progress. We have that roadmap. It's done it. I'm not just hypothesizing. There's clear evidence. I've given you some of that evidence. So I'll now briefly summarize 3 approaches actually in my research lab that we're doing to try to improve immunotherapy for patients with melanoma. One is trying to identify so-called predictive biomarkers of response to immune checkpoint blockade. We need to figure out for whom is this treatment going to work, for whom is it not going to work, who's going to get the side effects. I'll show you that strategy. We're trying to investigate new strategies to get more anti-melanoma T cells. We've got outstanding ways to take the brakes off. We can take that car on the top of the hill, get the brakes off very effectively. But we need to point the car down the middle better. And we're trying to get new strategies to make that melanoma better activate more more T cells that are anti-melanoma to then have more brakes taken off of those T cells. And then finally, we're also working with colleagues in the School of Veterinary Medicine to help pet dogs with melanoma. And by doing so, hopefully attain insights to help people with melanoma. So this cartoon summarizes our strategy to identify a potential biomarker. And actually one of our panelists this morning actually donated blood samples for many of these assays. We get blood samples from patients. We grow them under what are called selection conditions, where we can just pick up dividing cells. So we've got literally billions of T cells in our body. Using this strategy, we can only look at the so-called dividing T cells. We get rid of most of them. And then with those dividing T cells, we're trying to find the melanoma reactive T cells so we can specifically manipulate those T cells. And this work has been ongoing and is developing, and we're trying to figure out, are there ways we can best manipulate this response by figuring out those T cells specifically reactive to the melanoma. The second project is trying to get more develop a better melanoma vaccine, to try to get more anti-melanoma T cells. And this study actually started several years ago. It's an intratumoral, meaning injecting the tumor immunocytokine. It's an IL-2 immunoconjugate given with radiotherapy to deplete some of the cells we don't want in there, and then with checkpoint blockade. Again, this is with several colleagues. This was really a study based on a really exciting laboratory studies from the laboratories of Dr. Paul Sondel and Dr. Zachary Morris, friends and colleagues on the Cancer Center. And in mouse models, this clearly showed that you could do far better with this treatment if you gave it into the tumor, had the tumor activate the rejection response, and then could give checkpoint blockade afterwards. The study is on a temporary pause due to change in licensure for the agent. But again, this is a study that we're pursuing at the Cancer Center. And then finally, working closely with our colleagues in the School of Veterinary Medicine. Again, these are not dogs we give melanoma to. We haven't given melanoma to a single dog. Dogs get melanoma like people do. The average survival of pet dogs with melanoma is less than 6 months if it's spread. So it's a bad disease in dogs. And we're investigating new treatments to improve outcomes for the pet dogs and really doing many biopsies. So I'm not a veterinary oncologist. I work closely with them and get the samples, the blood samples, the tumor samples. We're trying to understand what things are occurring with these treatments to inform what we want to do in people. So my take-home points. Laboratory insights have improved survival and changed the standard of care for metastatic melanoma patients. I think that is pretty clearly demonstrated here. Immune checkpoint blockade can achieve durable responses in metastatic melanoma. Awareness of possible immune-related adverse events is essential following treatment with immune checkpoint blockade. We need better biomarkers, both of response and of toxicity, and a lot of enthusiasm to look at combination therapies. I'd like to acknowledge the many colleagues, both in the lab and clinical collaborators, who identify here just individuals for these specific projects. There's many other collaborators for other projects. I'd really like to especially call out Dr. Cindy Zuliger, a very talented immunologist in my lab, and also Dr. David Vail, who heads up our veterinary oncology program. Funding is important, both with the VA system, the NIH, but actually something I never imagined decades ago when I started was really the importance and the benefit of philanthropy. And Ann's Hope has been incredibly beneficial, supportive of our work developing these biomarker studies. Steve Lutho Foundation, the Tim Eagle Memorial. It's something when your patient is cured and they give you something, but when your patient passes and the spouse, now for 20 years consecutively, has golf outings to raise support, tells you something. So this philanthropic support is really key to get the initial studies, to get the federal dollars to go forward. And while meaningful progress has been made, much more work still needs to be accomplished for patients with metastatic melanoma. We got a road, the road's exciting, but the road basically needs to be traveled. We're doing this together. Thank you. And I'd now like to call my colleagues. We're going to have time for a Q&A session. So the four of us, Dr. Ma, who's not yet presented, but Dr. Neuman, Dr. Xu, and myself, and we'll be up here for questions to any or all of us as appropriate. Leave it.
We have a few questions from our online viewers, which I'm going to place here on the table in front of you. And then Allison is over here and I'll be over here. And if you want to raise your hand after they have gone through these questions, we'll hand the microphone to you and let you get your question answered. And here is a microphone here on the chair. Here's what we're going to do. We're going to switch. That's yeah. I'll get started. Okay.
They're working? All right. So my question, a couple questions, is great questions. Is there any safe way to tan? What safe way to tan is really just artificial tan. You have artificial tan that give you really low actually SPF. It looks tanned, but it's really not protecting you. But the look of it, if you want this kind of tanning look appearance, you can use it. But a lot of my female patients will tell me like sometimes it's a little hard to do to make it kind of even look. But that's the only safe way to tan. You really cannot tan in tanning beds or outdoor sun rays to feel that's safe. It's not safe at all. But again, I want to emphasize that the artificial tan make you look tanned, but it's not. You want me to answer another question or?
Why don't we open it up to the audience right now first? And we got a few more here as well, but let's open it up to the audience because again, there should be some reward for getting up and spending this beautiful morning with us. So.
Oh, yeah. The question is, how do you explain sometimes melanoma occurs in the sun protected area, like your buttock and so because sun exposure is not the only answer. It just kind of amplifies the mutation in your DNA, in your cells, and then just like your body couldn't keep up with the repairing of all these damages and mutations. So sun really plays a major role, but it's not the only role. So sometimes just takes the random mutation in sun protected area. And then you can still form skin cancer, not just melanoma, other type of skin cancer. Good question. Right here.
Good, thank you.
I put on 30 SP or BPS or whatever it is in the morning. And how long does it last? I'm going down to the library or running some errands and I'm in the car and I don't spend a lot of time outside. I'm either inside or very seldom outside.
Yeah, so you don't sweat a lot. So typically it lasts for a long time. I mean, the safe way to say like a couple hours, but if you don't really sweat, you don't jump yourself in the water, and you're probably good for the day.
Thank you.
Yeah, but if you sweat a lot, like every couple hours, right? Reapplication.
Excuse me, what role does genetics play?
Genetics is part of the answer, and there's actually a subset of patients who basically have a propensity. So there's certain genes. Again, this is probably well, I think more globally, it probably is more of a problem than commonly recognized. There's certainly a small subset of patients who have a much higher risk, multiple moles, multiple dysplastic nevi. So it used to be called dysplastic nevus syndrome. There's also, to take it even one step further, there are probably some genetic phenotypes that basically tend to burn more than tan, and to basically have the type of skin that is less able to resist against the sun damage itself. So I think as we understand the genetics, it's probably not quite as simple as saying that very small cohort who've got the familial melanoma syndrome, which I think is perhaps what you're referring to, another genetic syndrome. So those do exist. It's a relatively small amount of the melanoma burden. But a bigger piece of it is really those individuals who are lightly complected, tend to burn more than tan. And again, we're better understanding that makeup of those individuals as well. So. That's a great question. And again, getting back to my initial comment about early melanoma is curable, and then how curable and how early, so to speak. So there have been very clearly defined prognostic factors, one of which is the so-called depth, depending on how deep the melanoma is. Deeper is worse, thinner is better. So less than 1 millimeter, 1 to 2 millimeters, 2 to 4, deeper than 4. Then whether it's ulcerated or not ulcerated is bad, not ulcerated is good. Whether it involves the lymph nodes, no lymph nodes is better. Lymph nodes, depending on the amount of lymph nodes, and whether it's spread distantly. So there's not, it really depends on the specifics of the melanoma, in terms of the stage, but there's estimators out there that can predict the risk at various time points of recurrence, depending on all those variables.
I was just kind of like comment, because I do think even patients who have really thin melanomas, the risk is never zero. But the other comment I'll say is there's the chance of this melanoma coming back, but anyone who's had a melanoma is at increased risk of having another primary melanoma develop. And so there's the piece about this melanoma, if it's on your leg, coming back in that area, but there's also that risk that another mole or another skin area will change. And that probably is around, I had a research fellow who looked at this last year, and over a decade, it's probably around 7%, which is higher than the average population, but that's the justification for continuing to see Dr. Xu's colleagues for those had 7. Yeah, it's higher than the average population, but it's low, but it's enough to say regular skin checks is important.
And we'll now take a question from the internet audience, and then we'll come back to our actual audience. This is Dr. Monk.
Oh, yeah, thank you. So we got a question online, which is, has TIL therapy received FDA approval? So for those of you who may not be familiar with what TIL therapy is, it's a TIL, it's a tumor infiltrating lymphocyte therapy. And so this is actually a very exciting type of treatment that is actually being explored right now in the clinical trial setting. So there are a select number of academic centers that have this available as a clinical study. But what is TIL therapy? It's basically a means or treatment for especially stage 4 or metastatic melanoma, where you're removing some of the lymphocytes or the T cells and actually engineering it. And then what happens is you give a high dose interleukin-2 to these patients, and then you infuse these engineered T cells to work better on fighting the melanoma. And so as of right now, TIL therapy is being primarily investigated in the metastatic or stage 4 setting. And so what we know is that this is still an area of ongoing investigation. So it is not quite FDA approved yet. But so far from what we're seeing, especially since TIL is actually being mentioned quite a lot in the press, is that there's actually very promising results with it so far. And so we may be seeing an FDA approval of TIL therapy coming fairly soon. And then the second component to this question was, can it be used as a primary treatment? And so as of right now, it's primarily being explored in the stage 4 setting, where, as you can imagine, most of the death rates associated with melanoma are in the stage 4. So we're primarily investigating in the more advanced stages. But as of right now, because of how toxic the therapy can be, we're mainly focusing on the advanced stages at this time. And then to kind of follow up with the third question that's also fairly similar is, does TIL therapy work for all melanomas? And so as of right now, or excuse me, all types of melanoma. And so right now we're primarily investigating it in the stage 4 cutaneous melanoma population, but there at some point may be exploration of it into other subtypes of melanoma, such as the uveal melanoma, which is melanoma that exists in the back of the eye, or melanoma that originates from the mucosa, from anywhere between the mouth to the anus. And so it's a very exciting time right now for us to be exploring TIL therapy. And, you know, as a medical oncologist, we're very excited to hopefully see this become a new treatment option for our stage 4 melanoma patients.
Other questions from the audience? I want to, again, still give priority to the folks who are here with us this morning.
Yes, this question is for Dr. Neuman. Dr. Neuman, about 5 years ago, it used to be that you would have a sentinel node biopsy if you were a breast lobe thickness of approximately 1.0, but then it was lowered to 0.8 to 1.0 to have a discussion with your doctor as to whether you have a sentinel node biopsy. And I'd like to know the advantages of disadvantages of whether to have it or not have it in that window. And also, and that's assuming all other indicators are normal as far as the biopsy goes. Thank you.
So the reason why there's cutoffs is that your likelihood of having lymph node spread is based on that Breslow depth. The thicker the melanoma is, the higher the risk. The sentinel node biopsy is not perfect. There's some false negatives there where it will come back and say there's nothing there, but there might actually be something. And so those guidelines were sort of developed to say, maybe if you have a 7% chance of having something in a lymph node, it's worth the little bit of extra surgery and morbidity to do it. If it's below that, maybe it's not accurate enough. The other piece to that was what you do with the information. And so before there was any effective systemic therapies, you said, we might follow you more closely, we'll get imaging tests, we do this bigger surgery, but it didn't have as much of a driving treatment effect. Now that we have effective therapies, I would say knowing whether there's something there and opening the door to say you at least have the option to think about doing a year of adjuvant therapy that we know reduces the risk of something coming back. I think that's where we start having more and more of those conversations. And so I think our dermatology colleagues have been really great about referring us people to at least have a conversation in that window. And I will say probably the difference is younger patients who are really likely to think about doing systemic therapy are more likely to do it. Older patients who say, you know, I think I would probably just watch and wait and see if something comes back. And especially if I offer them the option of doing an excision in clinic versus doing the sentinel node and having it be in the OR, maybe more likely to say, let's skip the sentinel node. And so it's very much a conversation thinking about what are you going to do with the information.
We have another question right here.
you. My question is, what about the patients who have autoimmune diseases such as rheumatoid arthritis? Are they more vulnerable to a melanoma disease after they've been on long-term biologics?
There's maybe two parts to that answer. The question I was guessing you might ask, which you didn't, which I'll also answer, but I'll answer the question you did ask first. So certainly long-term on biologics can be a risk factor for many cancers, including melanoma. I think the question that comes up oftentimes in the clinic is that patients have an underlying autoimmune disease. Can they get these treatments that release the brakes in the immune system? They've been spending their life trying to basically downplay their immune system. And what happens if you basically throw fuel on the fire, so to speak? So kind of that was the unasked question, but the one that comes up incredibly frequently in the clinic. And the initial studies, that was a huge fear, and those patients were categorically excluded from many of the early studies. There have been data since then that in selected patients, you actually can do that. And a lot of that depends on what the what the autoimmunity is against. Are you able to, if that gets worse, help the patient get through it? So rheumatoid arthritis might be worse symptoms, depending how bad it is, what treatment is required, can they get off of their immunosuppressive agents? And actually doing that might also be a benefit all by itself. But as someone who's had a major organ transplant, such as a liver or a heart transplant, obviously you can't deal with that autoimmunity if that gets worse and it attacks that end organ. So to answer your specific question, yes, if you're on these long-term biologics, there is increased risk of many cancers, including melanoma. That's something that can be surveyed and monitored. The question that comes up often, though, are patients in the clinic who've got various autoimmune diseases. Can they receive these agents if they get metastatic melanoma? And the discussion oftentimes is, these treatments can result in long-term survival, even cures in some patients. So what risk is one willing to take? What would happen if that autoimmunity gets a lot worse? And that's really a shared decision with the patient.
Thank you, doctor.
Yeah, you actually figured out answer already. Yes, phototherapy, and it give you more, exposure to these UV lights. But it's a risk and benefit ratio discussion. If you have really like extensive atopic dermatitis, also known as eczema, if you have really extensive psoriasis, your other option might be, systemic biologics that we talk about. So like you weighing, risk and benefits, and phototherapy is still commonly used in dermatologic conditions. But these patients basically just need more frequent monitoring. They deserve to be seen by their dermatologist more frequently for skin cancer monitoring. The good thing about skin cancer is really it's something you can see on your skin. So as long as you monitor this specific population a little bit more frequently, and of course, patients doing phototherapy needs to be self-aware, right? They have more risk. So yeah, your answer's there, but we have to do it.
I'll take one of the questions from the internet now. If there are side effects of IPI November 1, how long does one wait before trying another therapy? And this comes up oftentimes. Patients, not just IPI, but Nivo, Pembro, the combinations of the treatment, Nivo-Rela, Nivo-IPI. How long do you wait? So again, this depends on what the side effect was, how serious it was. The short answer is you typically like to get the patient off of what was required to manage that side effect. The mainstay for these side effect managements when they're severe, so-called grade 3 and 4, is steroids, high-dose steroids, followed by a taper. So typically, like to get the patient off of the steroids for two reasons. Number one, to give them that recovery from that effect, but number two, to give your next therapy a better chance of working. But the other shared decision with the patient is your next treatment is going to have a defined risk of reactivating that same toxicity. So depending on which agent caused it, how severe it was, whether that's a risk that patient wants to take or not. So typically, there's no specific calendar date that can be put on the clock. You like to get the patient weaned off of the treatment if required to manage the side effect. And then depending on the level of the side effect, the toxicity, whether that's a risk willing to take. Another kind of expanded answer to that question is that you can re-challenge some of these patients. Someone who had very serious side effects with a certain agent, got a different type of agent with, say, IPI, and then got the anti-PD-1 drugs, and got long-term benefits. So again, it's important. It's an important question. There was a question back there.
I think people are doing studies, just kind of not a very scientific study, more sort of like look at cases and see if there's any increased risk of skin cancer. I'm not aware of any good studies out there yet, but questions is being asked. So it is very common. Yeah. Yeah.
How do dogs manifest melanoma?
So it's primarily in the mouth, actually. So it's more akin to the so-called mucosal melanoma in humans. I think why it's such an important model is that dogs are outbred like people. There's many different shared types of other exposures, but in terms of the location, basically, that's an oral manifestation. So it's actually one of the more common oral tumors in dogs. The other thing that they share with human melanomas are some of the same so-called markers or antigens. So I think that's kind of a good intermediary model between mice and man, so to speak, and women are man and women's best friend, which are dogs. One more question here, and then I think we're going to, oh, sorry. I missed that. Sorry. Great.
Protection standpoint, we know to have your skin checked, on a frequent basis. Can either or any of you talk about mole mapping and about the technology behind it? Is there any data or science behind it, and just general thoughts?
That is a really great question. Like at UW, at our Department of Dermatology, we haven't really used any mole mapping. We do actually do photograph, in different angle or certain angle. It's kind of like limited mole mapping, if you would call that. We do photographing and compare like a focused area, but whole body mole mapping, UW hasn't really started. And there's a few reasons for that, because like U of Michigan, they actually pioneered that, but they kind of dropped off. They're no longer doing that. It's a there are good data about mole mapping, but it's really, really, if you look at, so the benefit and, how much benefit you gain by this mole mapping versus if you just target on high risk area, do you photograph, serial photograph, focus on the specific area. I think the jury is still out if a full body mole mapping has more benefit. I'm not really saying that's now useful. It is useful. There are data out there, but it's for a lot of reasons, like a lot of centers now doing that. There are some devices out there now, like you can actually do mole mapping and then linked to the computer system, like artificial intelligence, that they can actually start analyzing, right? This mole is a change, like they can do better than human eyes when they look at one image to another image. So I think there will be new development, and then when that actually become more perfected, probably people will be adopting to mole mapping, because it has to be something more than just photographing. You see what I mean? Because the original mole mapping is more or less just like photographing in a more defined angle, and you probably have to hire like a professional photographer, and it's just very time consuming. I don't know if you know anything about U Michigan, because you train at U Michigan, because I know they're no longer doing that anymore.
Just one more internet question, then the other one saved. We'll have another session for the four of us up here again at the end of the morning. So the other internet one is, can you give me the statistics for life expectancy for patients who are still alive 10 plus years after the last tumor? Well, part of the answer depends on how old that person is. Again, if they got the tumor at age 85 and are 95, I will not give a huge number. So overall survival depends in part on their actual age. But melanoma-specific survival, which I think is what's being alluded to with this question, once you're 10 plus years out, most of the survival curves are pretty darn flat. So they're not entirely flat, but most of the patients graduate from my clinic after about 5 years, some after 10. But again, if you're at 10 years, have not had a recurrence is some cells that have been there all along, have been sleeping, and then wake up. Once you get past a number of years, 5 for the vast majority of patients, 10 even more, it's unlikely they were there in the first place. But as was mentioned earlier by Dr. Neuman, you can have a second primary, which can also spread, which may or may not be recognized. So people can still have melanoma later. And uncommon, you can have these delayed, really late recurrences. I've had a couple many years out. So yes, it can happen. It's pretty uncommon. 10 minutes, everyone gets either gets a bio break or or a food break, but 10-minute break, then we're re-adjourning here.
Yeah.
All right. Good morning, everyone. For the sake of staying on time, I guess we'll go ahead and get started. It's 10:45. So to introduce myself, my name is Dr. Vince Ma. I'm a medical oncologist like Dr. Albertini. I primarily focus on melanoma, but I also see advanced stages of skin cancer. And so today, I have the pleasure of being able to talk about some of the exciting clinical trials and studies that we have here at UW Carbone, specifically with the aim to improve outcomes of advanced stage or metastatic melanoma. So I'd like to just kind of mention a few disclosures as an advisory board position, as well as some of the research support that I have from industry. And so, as Dr. Albertini mentioned, in his lecture, we have a wide variety of different FDA-approved medicines to treat stage 4 melanoma. And as you can see here, really since 1998, there really wasn't much in terms of development for medicines to treat the disease. It really wasn't until 2011 where we've now seen an explosion of different therapy options that we have now available to treat the disease. And so I really want an opportunity to kind of highlight specifically the drugs and kind of understand what these drugs are. And so what's highlighted in teal are essentially your newer immunotherapy drugs. And the newer immunotherapy agents, or immune checkpoint inhibitors, as we also call them, are generally speaking drugs that we can generally use for nearly or most stage 4 melanoma patients. Now, in contrast to that, we also have the pink labeled agents, which are your targeted therapy agents. And so these are really applicable or frequently used or can be used for patients who have what we call a BRAF mutation, where their melanoma has a specific mutation or a BRAF mutation. And that occurs in about 50% of the population. And so really since 2011, we've really only had two major classes of therapies. And so as a medical oncologist, we're kind of stuck with the role of sort of deciding between which two classes to use, and of those classes, what agent to use in the first line setting. And so the thing I want to mention is that, melanoma death rates here in the United States was fairly stable. And it really wasn't until, as you can see on the figure there, 2011, where we're finally seeing a decline in the annual death rates of melanoma here in the US. And a lot of that can definitely be attributed to the advancements and the new medicines that we have nowadays to treat stage 4 melanoma, which, as you may know, stage 4 melanoma being a very deadly stage, a part of melanoma. Now, here's the thing, especially with regards to immunotherapy, which is commonly what we use in medical practice to treat our patients. So I'll be mostly focusing on immunotherapy. But the thing about immunotherapy is that not everyone benefits from treatment. And so what I have listed here on the table is that, the percentage rates or the chances of actually responding to different immunotherapy agents. And so you can see labeled up there that the use of combination or two-drug immunotherapy tends to have a slightly better response rate than, say, using one single agent of immunotherapy. Now, that comes down to a few problems, particularly with the current treatment landscape for melanoma. And the issues that we face as medical oncologists is that we know that there's a large proportion of melanoma patients, stage 4 melanoma patients, that don't respond to therapy. And to be honest, we are still developing newer ways to identify who is likely to benefit and who is not. And what we also know about immunotherapy is that the tumor, the same melanoma tumor that exists in the body, can respond differently to immunotherapy based on the location. And so, for example, what we historically know is that melanoma that originates or spreads, to the brain or the liver tends to not respond to immunotherapy as well as compared to areas like the lung or the lymph node. And so these are areas that we're still trying to understand a lot more as to why that occurs. Now, as a medical oncologist, when we see our stage 4 melanoma patients and start them on systemic or medicines to treat their disease, how do we frequently assess their response to treatment? And so we have a wide variety of imaging modalities that we frequently use. And so what I have listed up here are some of the most common ones that we typically use to actually assess a patient's response to treatment. And these include like MRI, a CT scan, or a PET CT scan. Now, when it comes to imaging, how frequent, how often do we typically do this? And so in the stage 4 setting, when we're treating our patients, we generally speaking do not perform these imaging until around 9 to 12 weeks after therapy. And that's a problemsome area, if you can imagine, which is that, for a significant number of patients who don't respond to therapy, they may be getting therapy unnecessarily and not responding to it. And as a provider, we don't know that until about 2 to 3 months later. So the question arises is, can we find a way to evaluate response even earlier so that we can potentially, as a provider, make treatment changes even sooner? And so I have here illustrated an example of what a PET CT looks like. And so we are now in the process of opening a new study here at the University of Wisconsin, primarily looking at the role of using a PET CT early in the course of therapy to actually identify if patients are responding to treatment even earlier so that we can make treatment changes even sooner. So why a PET CT, amongst all the imaging modalities? And so we use a PET CT because it really provides us the ability to get a global assessment of the patient's tumor status. We can actually assess where the cancer is located. We can see the size of the tumor. And the nice thing about PET scan is that we can actually assess the metabolic activity of the tumor as well. So it actually gives us quite a bit of information that we can use as providers to kind of assess how a patient's doing well with treatment. And so one of the studies that we're planning to open is where we're looking at the role of doing a PET CT much, much sooner than that 9 to 12 week period, and hoping to do it at around a 3 to 4 week period. So what is the potential goals of this study, right? One of the major goals is to be able to inform us as providers early on in the therapy course to see if a patient is actually benefiting from treatment. And what's also illustrated here is that you can also assess the patient's ability to whether they are responding to treatment or if there are certain parts of the body where the tumor is located that's not responding. And so by having that sort of information, earlier on, we can prevent the clone, especially the parts that are resistant, from propagating or spreading to other areas. And so by identifying, the areas that are not doing well, we can incorporate or change our treatment plans. And so, for example, we see areas that are not responding well, we can add the additional treatments such as radiation therapy. Or if a patient's not responding well holistically, globally, then that should be a decision for us to add on another agent or to change treatment altogether. So this is kind of the main vision behind why we want to do an early PET CT type of trial or study. Now, we talked a little bit about response to immunotherapy, but some of the things that we often don't mention too much, especially, are the side effects. And so what I have labeled here are some of the side effect frequencies, particularly the severe side effects that we typically see with immunotherapy. And what we can see here that, especially for the agents like ipilimumab and nivolumab, which are your two immunotherapy drugs, the risk of a severe side effect can be as high as 59%. And again, I'm mentioning severe side effects right here. Now, as Dr. Albertini mentioned, in his presentation earlier, the side effects of immunotherapy, which we often can call immune-related adverse events, can be very severe. When you're lifting the brakes off the immune system to fight cancer, what can also inadvertently happen is your immune system's attacking your normal organs, your normal tissue. And as you know, your immune system is located everywhere from your head to your toes. And so technically, almost any organ, your body, can be affected by immunotherapy. Some of these immunotherapy side effects can result in us as providers having to stop therapy. Some of these side effects can also be permanent. And in some cases, we have to use steroids, which are anti-inflammatory drugs, in order to calm the inflammation that is resulting from the immunotherapy side effect. And in some rare cases, these side effects can be deadly. One of the other advantages by doing the early PET-CT study that we're opening up fairly soon is that we can actually use that early PET-CT to actually assess areas where there might be a little bit of inflammation. So areas that are potentially at high risk of developing a side effect, even before the patient actually manifests with symptoms. And so the PET-CT gives us the ability to kind of look at areas that are a little bit more metabolically active, more inflamed. And so by having some of that information earlier on, one potential future solution that we have is we can potentially, for example, see the areas that are worrisome for developing a side effect, that as a provider, if a patient is doing well with treatment, we can actually use this information where we know they're going to get a side effect, that we can confidently feel comfortable just holding treatment temporarily while we wait for some of that inflammation to calm down. So the early PET-CT is a project that we're developing and has very much promise in terms of the future of being able to help providers like myself to kind of weigh the balance of the risks and the benefits of continuing versus halting treatment even temporarily. Now, some of the limitations that we typically see with imaging like PET-CTs, MRI, and CT is that it can be costly, right? These scans can cost hundreds, if not thousands of dollars. These scans also have the risk of radiation exposure. Patients can have allergies to contrast, and patients can also get kidney injury from these contrasts that are given for imaging. And one of the major things that we find, particularly with the current imaging modalities, is that we really cannot access very, very microscopic or small amounts of tumor. Nevertheless, though, we still use it, and we do continue to use it because it does provide the information that we need to know as oncologists, which is how well they're responding to treatment and assessing the location of the tumors. But the main thing we're looking for nowadays, and there's ongoing studies to do this, which is there a less invasive way? Are there alternative means for us to be able to see how well a patient is responding to therapy? And one potential avenue to do this is actually to do blood sampling, having patients donate their blood so we can actually assess and see, can we find microscopic amounts of disease in the blood and actually detect it? And so as you know, melanoma and other cancers can spread through the body, through the bloodstream. And so we can take advantage of that fact by actually looking at their blood, identifying cancer tumor cells or circulating tumor cells. We can actually identify things like circulating tumor DNA and actually analyze those samples and actually give us some information to know, for example, how much disease burden or correlate that with disease burden and potentially see how well they do over time as they're getting therapy. Now, this is still an area of ongoing research and is not yet quite standard of care at this point, but you can see that there's a lot of great advantages of this, right? It's accessible. You can get blood draws at any location. Serial sampling is a lot easier rather than doing an imaging every few weeks, right? And what's great is that we can detect microscopic disease. And even though at this point, it's still an area of ongoing development, it can one day, as we start to develop the assays even better, can become cost effective as well. Of course, the disadvantage would be for those who are afraid of blood pokes, having to draw blood from you. So here at the University of Wisconsin Carbone Cancer Center, we also have what we call a circulating biomarker core. So we have a variety of scientists who are members of the circulating biomarker core that are working on research for us to develop and develop assays where we can actually detect cancer cells, cancer DNA, and cancer proteins in the blood. And so since the circulating biomarker core was developed, we have over 1,000 patients, samples evaluating all those circulating tumor cells and DNA. And since I've joined the department a couple of years ago, we're starting to analyze stage 4 melanoma patients. And so an example here that I have illustrated on the bottom represents a patient who has cancer or melanoma that has spread to the lung. And so we can assess, for example, at baseline, and which is highlighted red, the circulating tumor cells. And over time, we can assess the number of tumor cells. And so what's illustrated here is in red, that since the patient is progressing, we can see that there's more lung spots, but there's a correlation, with the red dots. And that should be representative, hopefully, of the circulating tumor cells of how well a patient's actually responding to therapy. So this is still an area of ongoing research at this time. Another means and another test that we're also doing as well is the use of circulating tumor DNA with the use of Signatera. So it's a blood-based biomarker test in which the Signatera is made by a company called Natera, for which we're partnering with in order to actually assess circulating tumor DNA in the blood. So how does Signatera work? So what the testing involves is going back to the tissue of the melanoma and actually identifying specific mutations associated with your melanoma. And by doing so, you develop a very personalized test for you. And so by doing so, when you check your blood, you're able to assess, for example, the amount of that specific DNA that was assessed initially on that tissue sample. And so this is an area of ongoing development, and I will say that it is still currently research and not yet quite standard of care. But here at the University of Wisconsin, we are starting to use some of this test to help guide clinicians like myself, for example, in many means. What Signatera has been done initially is assessing the DNA levels before and after surgery, and then monitoring for the DNA levels over time to see if the cancer is returning. What we're now using it for is when the patients actually have stage 4 disease, where they have actual measurable disease, you can assess the baseline and then start trending the levels over time as you're being treated with therapy. So here's an example that I have down here of 2 separate patients. On the bottom left, we have a patient who has a baseline amount of circulating tumor DNA on the bottom left. And then over time, as we started therapy, we noticed that the DNA levels are starting to increase. And so when we finally got the repeat imaging, we're noticing a good correlation with that. And then to the figure on the right, we have a patient who had a baseline amount of circulating tumor DNA. And after starting therapy, their DNA levels went essentially to undetectable levels. And what we can tell so far, when we correlate that with imaging, that there is a good correlation with the DNA levels as well as response. One of the studies that we have available in partnership with Natera is called the Bespoke IO study. And so this is a multi-institutional study involving the use of circulating tumor DNA, specifically with Signatera, to actually evaluate response and correlate that with imaging. And we're also trying to assess whether the ctDNA can actually impact treatment decisions amongst providers. And finally, I want to take an opportunity to kind of discuss a little bit about some of the clinical studies that we have here at the University of Wisconsin. And so you can tell here, this is a bit of a busy slide, but the whole idea behind presenting is that there are many scientists and physicians working tirelessly to find different targets, different means for us to be able to treat melanoma more effectively. And so the development of cancer is extremely complex. And again, this is even a simplified version of it, but there are many ways that we can target pathways, ways to enhance the immune system so we can get patients to respond better to therapy. So, ideally, I'd love it more than an hour to maybe even talk about all the studies that we have available, but I just want to highlight a few of them that I'm excited to have here at the institution. One study in particular is more applicable to patients with stage 4 melanoma who have the disease that has spread to the brain, and specifically melanoma patients that have a BRAF mutation. So what we have, one major study is a randomized phase 2 study where patients with the stage 4 melanoma with a BRAF mutation that has brain metastases, they're randomized to 2 potential groups, one of which they can get Opdivo and Yervoy or Ipilimumab and Nivolumab, which is considered a standard of care regimen, or they can be randomized to the other arm where they can get encorafenib and binimetinib, which is another standard of care regimen. But you can also see there that you're adding a triplet, a third agent, which is an immunotherapy drug, nivolumab. And so the idea behind this particular study is to see, does triplet regimens make more sense to treat this very, very deadly population there? The disease, generally speaking, when metastases go to the brain, usually leads to poor outcomes. And so the overall goal of the study is that we want to see what their response rates are and how long they live when randomized to the two options here. Another exciting study that we have open, and actually just opened this past week, is this new radioimmunotherapy study. So this is a first-in-human study that we just opened, which is looking at the role of GD2-SADA, which is an antibody drug that binds specifically to GD2, which is heavily expressed by melanoma. But not only just doing that, but that antibody kind of has a second part to it, which allows the binding of the radiation treatment to it. And so this particular study is actually open to many different cancers, but is actually open to melanoma because we know that GD2 is actually heavily expressed in this type of cancer. And so the way this regimen works is, and it's fairly complex, but again, it involves the use of injecting an antibody regimen that specifically goes to the GD2, the melanoma, and then a couple or a few days later, you get a radiation treatment that also gets injected as well. This type of study also incorporates the idea of imaging, so you're able to assess the response to patient fairly early on. And then finally, another exciting study that we have is a bispecific protein molecule study. So this is a first-in-human phase 1/2 study looking at an agent with or without the use of immunotherapy in patients who have an HLA-A*02:01, which is an immune phenotype or a signature that patients have, and occurs in about 50% of the Caucasian population. And this particular study is mainly focusing on cancers that have the HLA-A*02:01 phenotype, but we also include patients with stage 4 melanoma who have exhausted first-line therapy. And so the way the drug works is that it has two components, hence the bispecific component to it, where one part binds to the actual cancer cell and the other that binds to the immune T cells. And so when that engagement occurs, that T cell releases a bunch of chemokines or cytokines, basically toxic things that then work directly onto the cancer cells. And so this type of drug is actually fairly similar to one that just got FDA approved for uveal melanoma. So melanoma that originates in the back of the eye. And so it's very exciting to now actually start seeing this type of agent being used now in the stage 4 skin cancer setting. And so again, I only highlighted just a very few small number of studies, but I'm always excited to say that there's always going to be more studies to come. And so things I want to mention is that, the University of Wisconsin is currently the only NCI designated cancer center here in the state. And we have over 250 clinical trials, and we're continuing to open many more studies, overall with the main goal of finding better therapies for stage 4 cancer, including melanoma. With that, thank you all for listening. And I will have Dr. Albertini come back up.
Okay, and now I'm actually very privileged to invite our patient panel to come to the stage. So our 4 patients who have volunteered to come today, if you could come to the chairs. And while they're coming to the stage, just by way of brief background, most questions will be answered by probably just one of the panelists, and the audience can direct questions to a specific panelist or can let them pretty much decide, who's most appropriate to answer. And we've got an internet audience as well. So as I had mentioned, most questions will be answered by just one individual, but I'm going to break that rule to start with. And I'm going to ask at the very beginning for each individual to basically give just some background about themselves their melanoma history to the extent they're comfortable doing so, and the current outcome. So I can either call names or actually, it looks like Steve Carpenter, so you've got a, do you want to start or?
Sure.
Okay.
My name is Steve Carpenter. I first had melanoma in 2011 and met Dr. Albertini in that year, I believe. And as far as my career goes, I am a limnologist. I work on streams and lakes of Wisconsin. And do you want me to give my 3 points?
Sure. I mean, I think in the beginning, just to kind of both introduce yourself and as much as you are comfortable, your melanoma history and kind of where things are at now for you. So this is first for the audience to really understand who the panelists are and kind of what their melanoma background actually is. And then we'll come back to specific questions and points and stuff afterwards. So in terms of my first question is going to be advice, but save that. And for right now, I think just giving a brief background both about yourself, your melanoma history, and where things are at now.
Okay, I think the only thing I would add on melanoma history is that I have had surgeries. I have had I guess it's called interleukin-2. It's what was that called?
That was the immune checkpoint blockade therapy that you had. Yes.
Okay, but then I had something that I injected. I had
That was the interferon.
interferon. Okay, I injected interferon into myself for about a year. And then I had a checkpoint inhibitor. There was a brain complication, so I had a sort of a space age, low energy radiation therapy that seems to have cleared it up.
Right. Okay, we just go in sequence. You can just say your name and a brief background. So Ron, looks like you're next.
All right. My name is Ron Parker, nicknamed Buck. I do a lot of farming, everything, worked my entire life outside. And I had my first bout with melanoma in 2004 with a scoop, and I ended up having stage 2. And then I was at the VA, and then I ended up coming down to Madison. That's where I met Dr. Albertini in 2005. Had surgery to remove the tumor, and inch deep by, I don't know, 8 inches long, wide to my elbow. In 2008, I had another surgery in arm, another tumor showed up. Oh boy, it just kept progressing. I kept having surgeries, 2008, 2009. I had chemo pills, and then 2009 again. 2010, I had radiation. And then I ran out of everything over there at the VA for my melanoma. So then I came to the University of Madison, where Dr. Albertini also was working. And then I started having surgeries there, and I did some clinical trials where they took blood out of a rabbit, took the 4 proteins out of that, put it into the tumor. No results. I just kept getting sicker. And I ended up with 6 months to live, and then he came out with another. It ended up being epi. I took that in Eau Claire, and my personal belief is the two together fought the cancer. It was amazing. I just had it on my armpit, come right out, and you just watch it fold in and disappear. So now I've been cancer-free for probably 12 years.
Hi, everyone. My name is Kirsty Blattner. I'm a professional speaker and have 9 more weeks of being a grade 2 teacher. I had melanoma when I was 3 months pregnant in 2016, one of the few cancers that can transfer from mother to baby. So rather than the pregnancy glow, I had the pregnancy woe. But luckily she was fine. So good news there. It was stage 1. So surgery, it was on my right jaw line. Surgery got rid of it. And then I think about 4 years later, it came back in the same spot. So then we decided to give it a dose of radiation and immunotherapy for 1 year. And so far, so good.
Kathy?
Hello, I'm Kathy Stokoyak. I'd have to say I was a buyer and now I'm retired. Happily retired. My cancer started in November of 2017. I had a spot in my upper thigh. And I went to the surgeon, they did a biopsy and found out that it was melanoma. And then on December, I had surgery on my thigh. And then in December, I had a scan and it showed melanoma in my lymph nodes and on my leg and my lung. So I had surgery removing lymph nodes on my leg. They hit the spot again. And let's see, from there. Let's see, for my surgery, I have to really thank my family. Got me through a lot of tough days. My daughter nursed me back to health after my surgeries. Thank you. She's right here. And I relied on them a lot to get better. Not knowing where I was going with this, you know, I guess I kind of walked in without, I don't want to say I don't want to care, but I, you know, kind of blind. So from there, Dr. Albertini, thank you, had me taking Keytruda. And we started out on 3 months of treatments. And then I had a scan and it showed that all of my cancer spots were dormant, small, non-changing. Wow. 3 treatments. I was amazed. I did have a couple side effects with Keytruda. I did have the rash. I had a rash from my head to my feet. Dr. Albertini had me take some cream. And I remember he putting in a prescription and I said, you know, make it a large jar, please, because I'm 5'9". I got a lot of body to cover. So I go to the pharmacy and he gives me these little tiny creams. I'm not kidding you. They were the size of my finger and I got 4 of them. And I looked at him and I go, really? What am I going to do with this? I said, doesn't this come in a vat? And he kind of looked at me and I thought, okay, so much for that humor. So anyway, just kind of a funny story. I also had some problems with the removal of my lymph nodes. I ended up with lymphedema in my leg. I tried many therapies, tried to massage it. Nothing really happened. Nothing really worked. So I kind of just got stuck with that. I do remember, you know, since I have been going back for scans, everything has been just normal. But I do remember in 2021, I had a panic attack. I had this neck that just throbbed and it was on my left side, which is where my cancer started. So I freaked. So on the phone to Dr. Albertini, and I'm like, oh my God, it's back. I know it's back. I just know it. And he talked me down my ledge, said, all right, calm down. And he said, it's probably just a muscle strain. Give it a couple of weeks. And yes, it went away. So
Amazing stories. We probably should go to the questions pretty soon, if that's okay.
Sure.
Okay. So again, really 4 incredible people, 4 incredible stories. Let me just Actually, do one or two of you just want to answer the question? What advice would you give other patients?
Sure. Can you hear me? Oh, here we go. All right. I made 2 pages of single space notes when Dr. Albertini asked me that question, and I boiled it down to 3 things that I have told friends in who had cancer of various kinds. First one is follow the treatment that's best for your chance of survival and your quality of life. And you're going to get advice on that from the experts at Carbone, Dr. Albertini, and in my case. But follow that treatment that looks best. And once you're in the treatment or the course of treatment, go all in. It's another job, and you just got to be there for yourself. Just go all in. So that would be point 1. Point 2 would be ask for help when you need it. The Dr. Albertini and other doctors there will help you out, and also the staff at a Carbone know an amazing amount. And just ask if you've got a question, and they'll help you understand what's going on. And the third point is keep doing what you think is important. Whatever parts of your job, your life are meaningful and important and worthwhile to you. And, you know, those might be your work, your family, your hobbies, your outdoor recreation, your exercise, whatever is meaningful to you, just keep doing it, because that will help keep your morale and energy up. To deal with a disease, which is just another job. It's a management problem. You're working 2 jobs when you have cancer. You're managing the cancer, and you're managing the job or jobs that you had before.
Very thoughtful words. I'll let each person say if they have anything else to add to that list. Ron?
Yeah. My rule was, I don't let cancer rule. I ruled it. Dr. Albertini knows that when it comes to my fishing, I put the cancer on the side and I went fishing. So that's the main thing. It all starts up in the mind. You've got to have positive all the way. Don't give up. If a roadblock comes up, go to the next step. That's what I did.
Kirsty?
So 100% agree with what my new friends here said. And for me, I thought about what would be in alignment with who I am to make me feel better. I love to dress up. So I asked my husband if he would dress up for me every month when we went in for our immunotherapy visits. One of my favorite moments was when the nurse didn't tell Dr. Albertini that we were in costume, and he came in, I don't know what we were wearing, bless his heart. It was just wonderful.
It was a side effect of the treatment.
Just bringing some, clearly this is very serious. And for me, I was extremely lucky in the type and the response I had. And also just finding ways to bring joy in and sharing that with others.
Kathy? Then we'll open it up to the audience.
Just everything of, what you guys have said. I think it's really important to maintain a positive image. And if you do have questions, go to your doctor, find out answers. And my family has helped me a lot, and my friends. So I have all of them to thank.
Okay, great words of advice. Let's open it up both to the internet and to the audience here. So as before, just so indicate if you have a question to ask. And we can run a little over in this section. We've got a Q&A at the end, which is an overlap from the end of the morning. So we'll make a little bit later for this part, and then we can finish up with the other parts afterwards. So from the audience first.
I'll ask a question. So my role is to this is Ann, for everyone who's online. My role is to be oftentimes the first face for AMIT melanoma when people call and they're newly diagnosed and they're seeking information and connection. And what people will express is a sense of isolation, even if they are surrounded by people who love them. their family, their church community, their friends. And so talk a little bit about how you built a support system for you. How did you communicate with the people that you loved about how you needed to be supported?
Well, I started by telling my wife about it and she was pretty calm about it. She said, "Hey, find out what the best thing to do is and just do it. Do it really hard, work really hard at it," which fits in with one of the points I made. My friends at work and my colleagues at work were just great, and I told them about it, and they were supportive, helpful, and I tried to keep doing my job through the whole thing. When I was taking interferon, I just moved my camping pad and sleeping bag into my office because I needed more naps. And everybody knew that if Steve's door is shut and says he's napping, he's napping. Let him take his nap. So,
Great. Other questions from the audience? So the question was, how do they handle insurance problems? Do they encounter that? Did any of them encounter that? So if any of you encountered insurance problems, how did you handle it? I guess I'll rephrase the question.
I didn't have any personally, but I've heard that Gilda's Club has an incredible specialist there that deals with that, and their doors are open to everyone, any type of cancer, and they're really good at helping navigate that.
And I'll add, and also to talk with your doctors too, because I think oftentimes there's appeals and things at the provider level that can be added to the patients as well. So again, sometimes that can be helpful as well. Other questions from the audience?
Yeah, I'm a huge hippie at heart. And so when I got the lumps and bumps from the immunotherapy, I read a lot of books on natural ways to help them. And I don't know how much was mindset, how much was placebo, but for me, it was peace of mind. I'm taking this chemical and this drug that's really incredible. And because I didn't have it to the point of being so severe that I needed medication, I was able to use alternative things on my skin that helped. And for me, part of my job is, talking about mindset and positive speaking. So one thing I did when I was pregnant and having a scan that was very, very loud was just saying affirmations in my head, about love and healing with my baby and imagining hearts going around. And it sounds silly, but it's somewhat soothing, just putting that out there. And huge advocate of meditation.
And with the questions from the internet, I guess I don't see those here, so I don't know if you were getting any questions from the internet or not. Okay. Other audience questions? I mean, one I'll ask is, how did you stay positive for any of you? Clearly, each of you had challenging situations as you described. How do you stay positive?
I have to say, when everything started, it was very hard to stay positive. I was always ready for that shoe to fall. I think sometimes the longer or the farther it gets out, just a little bit easier. And I know eventually I'm going to have a scan, and I try to save it all up and, have a little panicky at that point and try to live my life.
Other questions from the audience?
We did it.
Your initial lesion of concern that ended up being melanoma, did you find the initial lesion of concern and went in, or did someone else find it on you and then you went in?
To answer this one. My mother was a nurse and I had a mole here, a beige mole that had a little dark spot on it. She kept telling me, son, you better get in and check that out. You know, you probably got melanoma. Well, I kept putting it off. And then one day she come in, no, son, you gotta go in. That's just not right. So that's what I did. I went down to the VA and I had the scoop, and I probably would have went in when she first started about a year before. I probably only been stage 1 and ended up being stage 2. It helps have people coax you a little bit.
For me, I could also visibly see, I called it a volcano on the side of my jawline, and it was changing, shifting. And it took me also a long while before I got it checked, but it was noticeably visible.
What many struggle with is the challenge in terms of the outcome with various imaging to look for recurrence and the stress and anxiety associated with doctor's appointments and imaging and trying to find that out. How do you deal with the anxiety and stress of upcoming imaging and having to see someone like Dr. Mon or myself? How do you deal with the stress and anxiety associated with imaging that might show recurrence and going to doctor's appointments to go over that imaging result?
You know, with every image, every time you go in for an image, you're thinking, uh-oh, you know, this one's the one where there's going to turn out to be a cantaloupe in there, cantaloupe size thing. And so you do worry about it, but Dr. Albertini calls as quickly as he gets the data. So that removes quite a bit of anxiety. And now they post it on my chart pretty quickly as well. And I don't know if I'm answering your question, but I'd say just quick information is. Another thing that I tried to do and was successful in doing, and maybe it's just because I'm absent-minded and don't pay attention to enough things, is I just dug into jobs I really like doing, activities with friends, people I like, activities with family that I like. I just jumped into those, and somehow melanoma kind of fell into the background while I was doing things I liked.
Yeah, I like that. I had the stage 4 melanoma and I had the epi done at Eau Claire. And then I transferred back to Dr. Albertini here. And the imaging that was about the only time I really wanted to see the imaging, because the cancer was disappearing. I was coming every 3 months now. I just couldn't wait to see getting smaller and smaller and gone. Imaging, it does good work.
Okay, any questions from the internet? And last call for our audience. Well, I think a round of applause is appropriate for our outstanding panel. Okay, I think Anne, I think you're next.
It doesn't have anything of it. Oh, yes, it does. Well, I'm back, and I want to start by saying I know that you share my feeling that these presentations today are filled with hope. And That is what these symposiums are for, is to connect with people who are living with melanoma and let them know that these are days when sometimes you will hear researchers actually use the word cure, which is amazing, and certainly is not a word that they would have used maybe even 5 years ago. So what I want to do is tell you a little bit about AIM at Melanoma and our journey and our intention to partner with you while you are going through your treatment journey. For those of you who don't know, AIM at Melanoma was founded 19 years ago by Val Guild when she lost her precious daughter, Charlie, at the age of 26 to melanoma. And at that time, what she found was that there were differing ideas about treatment, maybe not a lot of collaboration internationally. And what she wanted to do was create a foundation that was focused on curing melanoma in our lifetime and supporting those who are living with melanoma. So this symposium is a part of that effort to find cures and to disseminate information about effective treatment. And my role, I want to reintroduce myself to you. I am Ann Garce-Taylor. I am the Director of Community Engagement for AIM at Melanoma. My role is connecting you to the information that AIM at Melanoma has put together, resources that we hope will help you through your journey. So what I want to do is, see if I can get it to advance this way. There it goes. Thank you so much. I want to introduce you to our organization and our website. We have a wonderful website that is filled with relevant information and current information. It is important to us that you have the information that you need and that you don't have to search the internet for conflicting information. It is a real soup to nuts website. It starts with everything Melanoma 101, everything from the various stagings, the treatment that is most effective at those stages, side effect management. People who are going through immunotherapy want quality of life, and we want you to understand what possible side effects there are and how you might be able to manage some of those. We even have a clinical trials matching service, and I would be happy to talk to you more about that. Now, if you go online and you do not find the answer to your question, we have an absolutely wonderful program called Talk to a Medical Expert. We have a PA, Melissa Wilson. She works with Dr. John Kirkwood through UPMC, and she will take your questions. We have a form online you fill out, and she will answer questions for you. Now, is she there to alter your plan of care? She is not. She is there to help you understand things like perhaps a question about your pathology report you didn't understand, or why a test is the next stage for you, those kinds of things. She's been doing that for our organization for about 2 years now, and as a result of that, there are what I would call most frequently asked questions. So what we ask her to do is to put together a webinar series. And so if you look up here, you'll see that she now has a webinar series called From the Clinic to the Living Room. And so these are topics taken from those questions that she gets again and again through the website. And I want to give you an example of a couple was, she did one recently on questions she's gotten about the cancer vaccine. And if you haven't heard about that, I think we now have a question for the follow-up question and answer period. In addition to that, we have a podcast. Our panelists today, our patient panelists are a perfect example of that. Not everything that you discuss clinically with your oncologist is what is impacting your life. You have questions about anxiety, diet, exercise, getting along with your family and friends. What do you do about work circumstances? Things like that. And so Dr. Ray Liu, who is with Kaiser Permanente, has a podcast that we do every month on the various ways in which cancer impacts not just you, but your caregivers and everyone that you love. In addition to all of this information, the other thing that people want to talk to us about is connection. How can I connect with the melanoma community, with people who really understand what I'm going through? We have a program called Peer Connect. It is a peer-to-peer program where we take someone who has completed their journey. They either have no evidence of disease or they're in a stable condition, and we pair them with someone who is newly diagnosed so that they have an empathetic ear, someone to talk to. These are not clinical questions. These are questions about living with melanoma. And if you are interested in being connected with that, then I will be here afterwards, and I will be happy to send you more information about our Peer Connect program. The other thing that is an example of community is this symposium. I was talking with Bonnie earlier, and we shared that with each other, that being in this room together is an opportunity to be to be in community and be with other people who care about melanoma, care about treatment, and care about eradicating melanoma. So here we are together. Another way to do that is to be a part of one of our walks. I am not an expert on that, but I'm going to introduce you to some experts. I have with me today the family of Dead Lupin. She is our melanoma walk, our Steps Against Melanoma walk coordinator here in Wisconsin. And I want you to hear from her family about that opportunity to be a part of an event that raises awareness and furthers the cause of curing melanoma. So I want to introduce you, please, to Nicole Merriman and Bridget Schrader, and two of the cutest little melanoma advocates you ever saw.
Thank you for having us. I apologize if my voice will be shaky. I've never spoken publicly before. We wanted to start by sharing a little of our sister's story. This is our sister Erica, pictured here with her sweet son, Houston. Erica was first diagnosed with melanoma about 9 years ago after a mole was removed on her back. She was diagnosed as stage 2B with ulcerative properties. However, her lymph nodes were clear. Unfortunately, after having consistent skin checks for the next 5 years, a tumor surfaced on her lung. Her treatment journey started and consisted of 2 years of dual immunotherapy, Yervoy and Opdivo, but the melanoma resisted. Since her melanoma did contain the BRAF mutation, she was eligible for the gene-targeted therapy. I can tell you she had the best year while on this treatment. She took a 10-year anniversary vacation with her husband to Jamaica, which was one of her favorite destinations, which previously had to be rescheduled due to some illness. And she took her husband and kids on a Disney cruise. Sadly, our sister's melanoma did become inhibitor resistant and her tumors came back and her journey. Her journey did come to an end 6 months ago on November 15th, 2022. While we continue to mourn her, we are thankful for the time we had and the memories we've created. I encourage you to read more about our sister's story on the AIM website. We also wanted to speak to you today about the walk. AIM Block Melanoma 5K and 2K walk that is scheduled for Sunday, June 11th at Frame Park in Waukesha. We hope you will join us. After our sister's passing, my mom and I wanted to know how we can get involved with spreading awareness about this disease. We were led to AIM, who just so happened to be looking for coordinators for the annual event. It was perfect timing. And my mom has been a rock star at coordinating the walk and collecting sponsorships and donations. 100% of the funds raised support programs for patients and families of patients suffering with melanoma and research for cures and treatments for this disease. Not projected here, but We do have postcards printed and available outside with a QR code. You can scan to join our team. We would encourage and love to have you join our specific team, Erica's Entourage, or you can create your own team or simply just sign up and come walk. Not only is this a great way to raise funds, but it helps bring awareness and educate others on this disease. We are grateful to share our story with you. Bridget and I will be available after the event today to talk or answer any questions you may have about Erica's journey. Before we go, we do want to say hello to our amazing mother, Deb. She has made it her mission to team up with AIM and raise as much awareness to others as possible. She couldn't be here today because she's down in Huntsville, Alabama, where our sister lived. She is celebrating our sweet nephew's birthday, which just so happens to be today. Happy 9th birthday, Houston. We love you. Thank you for your time. And now we'll hand it back over to Dr. Albertini for the Q&A.
Okay, I'd like to invite Doctors Neuman, Gloria, and Vince as well to come up and join me. So this will be a continuation of where we ended the mid-morning break. And just wanted to give another opportunity if folks had thought of certain questions for any of us, either here or on the internet. If so, we're here to answer. Again, we ask that the questions be more generalized, not just individual specific. Any of us are certainly happy to address those on an individual basis. And actually, we had one left for the morning that I'll let Dr. Xu start with.
Yeah, that's from online. Is that from online or it's actually written question says, are the chemicals in spray tans safe? So the spray tans, it's my least favorite type of sunscreen because really it works. But if you actually don't spray, I mean, it kind of goes a lot, in the air, you're really not getting protected SPF. That's one thing. The other thing is that really it's not good to use it in a closed door, right? You want to have open space, open air, it kind of evaporates because you don't want to breathe a lot into it. But it is marketed and it's one type and it's easy for a lot of athletes like my kids. They have to use it on their body. They will use lotion or cream and on their face and neck, ears, but they cannot really do the whole arms and legs. They have to use spray. So I always tell them just to in open air and not in closed door. So it's okay to use, just don't breathing. And I think probably a year or two ago, there's some questions about, whether there's some toxic components in the sunscreen. And it turns out it's really just the contamination, like a benzene contamination in the chemicals. It's not really the active ingredients. It's a contamination. So if you got proper products on the market, you should be okay. So in other words, you can use spray, but just use with caution. Yeah.
Okay, other questions from the audience? Okay.
Thank you. My question is also about sunscreens. So I usually use like a 50 to 60 SPF, but I see that you can sometimes get 70, and higher numbers. So, and I remember your slide about the percentage of effectiveness, but, all things being equal, sweating,
Sure.
not swimming and so on. Do you really need to use something that's 70 or 80 or even I saw some hundreds, or is like 50 to 60 sufficient?
So the official guideline that our Academy of Dermatology posted online is really 30 or higher. So we have most data about 30 higher because it remind you from the numbers I showed. It's like you block 96.7% with the SPF 30 already. So people actually, this is a good question. People do studies. I think there's one case series published in our dermatologic journal. They compare SPF 100 versus maybe 50 or 30. And there is a marginal benefit of using SPF 100. So I'm not discount that data, but overall, like, if you use SPF 30, I mean, they already block majority of it, and a lot of sun protection, you cannot really just rely on sunscreen, right? You have to do application, as I said, you have to do other means. So the marginal benefit you get from the higher number is really very marginal. That's why we don't emphasize on that. But, if you use 100, it's not wrong either, of course, right? You might get a tiny bit more effectiveness from that small study that we have.
Okay, there was a question from the internet. If my side effects become intolerable, how long do I need to hold out so that my immunotherapy is still effective? And again, this isn't one answer for all side effects. I've had patients who've had one dose of ipi/nivo and had almost like multiple sclerosis type of neurologic side effects. And that person was not treated again and had years of benefit from that one dose. I've had many patients who've had like 3 doses and had bad colitis and other types of side effects, recurring stopping, some of whom I think have been cured. They're now 5 and 7 years out. So again, you may need to go back on treatment. There's not a one answer to really satisfactorily address the question. Again, it depends on the nature of the side effect, the extent of the disease, the response of the cancer. But it's been amazing some of the responses that can occur even without ongoing therapy afterwards. So again, what you're trying to do is trigger the immune system to attack against the cancer. At some point, that becomes self-perpetuating. We need a better test to know when that's going to be. But again, I think that's an important shared decision with your treating oncologist.
I can answer that, sure. Actually, I'll follow up on what Dr. Albertini mentioned, which is, the severity of the side effects. So it's not uncommon, as I mentioned with some of the treatments we have, that these side effects can be pretty severe. But I've had some scenarios where even patients where, after getting, say, Opdivo, Yervoy, or ipi/nivo, that they get a severe side effect where I actually have to withhold treatment and give systemic steroids. And even some rare cases, I've actually had patients, even after holding therapy, they still continue to actually respond to therapy. Now, it doesn't happen for all patients, but what we do and what we are starting to learn about these immunotherapy or immune checkpoint inhibitors is that they can provide some durable benefit. And so there's still ongoing studies right now to actually correlate and see what these side effects and the severity of it and how that actually impacts long-term outcomes.
So one little sidebar. So I think we're in full agreement both in our experiences and comments. But again, if you do get bad side effects, there are occasions where you need to, again, get retreated. And depending on the side effects of the next agent, that is still possible in the setting, but there may be higher risk of those side effects again. So again, that's another shared decision with your treating provider.
Thank you. All right, so I got a question from the internet. As much as I look forward to it, what is the best post-cancer treatment? So this actually does vary and depend on, the staging of the disease for which you had completed your therapy. So what I would say is, for the earlier stage of disease, post surgery, for example, after removal of the melanoma, I think an important emphasis, and many of us would agree that it's important to continue surveillance. And some of the surveillance planning may involve, for example, doing surveillance skin exams. So following regularly with your dermatologist. And I can certainly have Dr. Xu speak to some of the recommendations that dermatologists typically recommend. Now, what we really didn't talk too much about today was, what do we do for the stage 3 melanomas, where they have a higher risk of the disease coming back as a stage 4. And so in these particular scenarios, we usually do and frequently do see these patients in our clinic where we actually talk about using some of the drugs I had mentioned for stage 4 and actually using them in the adjuvant setting. So in the adjuvant, which refers to giving it after surgery with the goal to prevent the melanoma from returning, whether it's coming back on the skin, the lymph node, or anywhere else in the body. And so in those cases, we do have available drugs or FDA-approved drugs for which we give a year's worth of treatment. But following that, we do say that these patients are still at high risk of recurrence. And so some of the things that we may recommend as medical oncologists after completing therapy would be frequently coming in to check in with us, following closely with our dermatologist, and sometimes we incorporate imaging. So some of the things I had mentioned would be like CT scans, PET scans, and MRI. And it's important, and what I always emphasize with a lot of my patients is that during the surveillance period, it's important that when you're at home that you also continue to monitor yourself. Monitor for anything in terms of your health or changes in your skin that you should be letting either your medical oncologist, your primary care doctor, or your dermatologist know. And so that's an important part of like long-term monitoring when it comes to post-treatment care for melanoma.
And just a quick follow-up on the dermatologic surveillance, like after your onset, first diagnosis of melanoma, you actually typically see dermatologists every 3 or 4 months for the first year, and then every 6, maybe second year, and then eventually just annually. That's sort of the most standard thing we do.
We have 2 other questions from the internet that I think are pretty related. So the first is, my designation is stage 4. Does that designation go away? Or once it has metastasized, am I more likely for recurrence? And then the second question was, does melanoma go into remission? And so I'll sort of answer them and then I'll open it up. Staging is something that is really categorized at that time of the first presentation. So once you have that stage 4 label, that's sort of the label that goes along. And I think inherent to that is the fact that there is a little bit higher chance of something coming back. I think it's all a little bit different with immunotherapy. Remission is not a word that's been used for solid tumors like this. It's a word that comes over from leukemias and lymphomas, where you do have a different disease progression. But I think that idea of, can you be without evidence of disease, that's NED. I think that is true for melanoma. And I think while we've not ever historically used the word cure for melanoma or for other solid tumors, I think immunotherapy is inching us closer there. That idea that the immune system attacking things maybe does get patients who've had stage 4 labeled on them. Maybe they really are at a place where functionally nothing is likely to come back again. So that question of maybe you are cured in the way that we can think about it. I think the challenge is hard to know if we think there's that complicated balance between the immune system keeping it in check. It only takes a few cells to come back. But I think without question, with the new immunotherapies, we're really seeing patients who have had disease go away and stay away for a long time. And I think they haven't been around long enough to know whether that really means forever, but it means 5 years or 10 years. And so I think that those are questions that are still in evolution. They're in that changing area.
Are there other questions?
Yes, I had a question regarding testing of the biopsy tissue for genetic or probability testing as far as the future of the chance that you would have a recurrence of, and how helpful that would be to the doctor.
Sure. I can definitely answer that question. So, there's actually a few tests that are existing right now, still being explored in more of like a research setting to kind of see if we can actually look at specific mutations of melanoma. So specific signatures of the cancer that can actually predict the likelihood of the cancer coming back, whether it comes back in the skin, the lymph node, or elsewhere in the body. And so what I had referred to earlier with regards to some of the biomarker or the blood-based studies where we're looking at these mutations, they're used to actually design as an assay to kind of monitor and assess, for example, the chance of the disease recurring or whatnot by measuring the DNA levels or the tumor cells. But right now, it's still an area of ongoing development. So for example, one particular company like Castle Bioscience is now looking at specific gene mutations associated with earlier stages of melanoma to actually help predict some of that outcomes. But as of right now, it's still in more of a research setting. And so right now we can't confidently say that this is something we're actively using as standard of care, but it is something that's in the process of being developed. And we may see more information and how helpful that might actually be down the road.
Okay.
I'm just going to comment because it comes up a lot for surgery. And I think this company in particular has had a lot of questions of, can we use this to predict people who are likely to have a positive sentinel node or not? And I think I think the data is not quite there yet to use it as a replacement for the surgery. I think whether or not there's something in the sentinel lymph node has such important prognostic implications and for treatment selection is you have to be really, really confident that the genetic information you're getting is accurate enough. And then you weigh it against the morbidity of doing a sentinel node, which is relatively low. And so I think the burden of it is they have to be really, really right before we can really use it to replace one of our key prognostic pieces.
Yeah, and I think consensus with, I think it's an exciting technology is being developed, many different gene platforms, not just Castle Biosciences, but others also. So there are many different exciting gene platforms still in development, still research, not yet standard of care. So Okay, I think we've come to the hour. I'd like to just say a few words of thanks to my outstanding colleagues. As is probably obvious from our interactions, not only are we colleagues, we're actually friends. And I think the close collaboration, the working closely together, the common mission, the dedication is something that I've really been amazed with my colleagues here, the ones on the stage here, and even others at the UW. I'd like to thank our amazing patient panel. I'm privileged to be each of their oncologists. They've trusted their care to me. That's something I take incredibly seriously. And today they've come to share their stories. And I think the message here is we're all in this together. Look around. We're all here for a common reason, a common cause, different paths to get here. Together, we will make further progress against this terrible disease. So go enjoy, have safety in the sun today. It's a great day.